That's a lot. Oops. Can you hear me? This is a little bit high, guys. Am I allowed to lower it? Can everybody hear me? Good morning, everyone. Thank you so much for joining us today. We want to welcome everyone that's in person. We also want to welcome our streaming audience. We have a couple of people coming in from all over the world, and we really appreciate you spending your Saturday with us. I'm Susan Bizarski. I'm the executive director of Lupus LA, and on behalf of our board of directors and our staff, we appreciate you being here. We have an amazing day of programming, fantastic speakers, and we have a roundtable discussion with our patient advocacy panel at the end of the day. We really encourage you to stay. These women are very diverse in their careers and in their lives and in their disease. And in the past, we've had some really intimate and touching discussions. And so if you're able to stay, that's one reason. Also, the incentive that our raffle is pulled at the end of the day, and you do need to be in the room to win. Just a little bit of business to get out of the way. Everyone in the room has a blue folder. Everyone online, you have all the documents in a PDF attached that you can download. In this folder is the agenda, the bios for our speakers. We encourage you to look at that. The bios for our patient advocacy panel. Fate Therapeutics is going to speak today. They're one of our sponsors. They have an exciting trial. They have information about that. They're also at a table outside along with AstraZeneca. We encourage you to go out and speak to them. We have a little bit of information in there about our resources, our support groups, which are virtual. People come in from all over the world. We encourage you to follow us if you don't already at Lupus LA, all social media, or join us on our website. All of these links keep you up to date on everything that's going on monthly in our organization. In addition to the folders here, we have white index cards. If you've been with us before, you know that they are for Dr. Wallace's lightning round of questions. You can also participate online. Mia Gunzenhauser, one of my colleagues, will be fielding questions to us in the room, so nobody will be left out. We'll take questions in the room and virtually. I think last but not least, we want to let you know that there is live translation in this room. There's also translation online. There's also American Sign Language, as you can see right here. So we wanted to make sure it was accessible for everyone. Last is we have a survey in the folder. So if you've been here before, a lot of our surveys have been, how is the conference going and what went well and what didn't. This time it's a little bit different. We're really looking at assessing our programs. All of our programs and services are done with the patient in mind. We really want to get an idea of the impact that they're having or not having on your care and your journey. So if you can participate, we'd appreciate that. There's a QR code both online and in the room. If you don't want to fill out the form in the room, of course, you have the option of filling out the form. Before I introduce our first speaker, I want to let you know that in between our speakers, you're going to be introduced to Maggie Sepkowitz. She's our virtual care coordinator. Maggie helps with one-on-one help, doctor referrals, all over the country. She also manages our emergency grant program, which is unique to Lupus LA, where we provide funds to lupus patients to help with medical copays and dental copays and a variety of bills. We don't give money straight to the patient, but we do help with a third party. And now that we've nationalized this program, we are seeing a lot of need all over the country, and we're very happy that we can provide that. Okay, it is my pleasure to introduce one of the co-founders of Lupus LA, a world-renowned rheumatologist, and an incredible asset to myself and to the staff for information and for doctors and knowledge about research, Dr. Daniel J. Wallace. While we have a second, also, if you guys have any questions in the room, any questions online, you want to reach us, info@LupusLA is read by myself and my colleagues. We always get back to you within 24 hours. So please reach out. Dr. Wallace.
Okay. So should I
Yep. You good?
take the,
Mhm.
well, maybe I'll start sitting up here. Good morning, everybody. I'm Dan Wallace. I helped start this organization 25 years ago and seen it thrive. I'm going to talk about some new approaches in lupus. I just got back from London, where the EULAR, which is the European League Against Rheumatism, met. It's the European equivalent of the American College of Rheumatology. They had 15,000 rheumatologists there and 2,000 research presentations. So a lot of what I'm going to say is based on newer material. By way of background, lupus is about 25% genetic. In other words, if you were one of an identical twin and a female, your twin sister would have a 25% chance of getting lupus. But that means that about 75% of lupus has an environmental component, and there's lots of abnormal immune responses that lead to inflammation and damage. So from work done in the 1990s, where recruits to the US military had blood drawn every year, and the blood was stored in a national defense repository in Oklahoma City. And there were several 100,000 recruits in the early 1990s. And of that group, about 400 developed lupus over a 10-year period. And they looked back over their ANAs and antibodies and found that over a period of time, there was first benign autoimmunity, which led to pathogenic autoimmunity and development of antibodies and accrual of tissue damage. And certain antibodies, such as anti-SSA, came early, anti-DNA came late. So this gives us an idea as to the evolution of lupus over a period of time. So I'm going to talk for about a half hour, and then we will have questions and answers about 10 different topics, which are here. The first is the genetic components of lupus. We talked about the identical twins. We talked about that 10 to 12% of lupus patients have an effective first degree relative. But what's interesting about lupus is that there are two types of lupus. There's monogenic lupus and polygenic lupus. And monogenic lupus is when it's from one gene. And polygenic lupus is when you have multiple genes. Monogenic lupus is responsible for about 10% of pediatric lupus. And it is an area of great interest because for research purposes, people with monogenic lupus have more serious disease. They all develop interstitial lung disease, nephritis, and any cures for lupus will be more evident more quickly from studying monogenic lupus. So it's a distinct variation of lupus, and there were a lot of papers at EULAR about some of the 30 genetic variants that have been identified. At Cedars-Sinai, where I am, we have a monogenic lupus center. We have about we have about 20 families that we are studying with Caroline Jeffries, who's our PhD immunologist. And basically, this is a new area that is rapidly progressing. I mentioned that 75% of lupus is not genetic or has a non-genetic component that's prominent. And there's something called epigenetics, which is where histone acetylation or microRNA or hypomethylation play a role in the environment. And these environmental factors that have been shown to be associated with lupus from newer papers include air pollution in particulate matter, smoking, pesticides, certain diets that are methylated, and the microbiome plays a big role. And believe it or not, emotional stress can alter your immune response. So some of the factors occurring associated with lupus include cigarette smoking, oral contraceptives, heavy metals, ultraviolet light from the sun, silica from implants or sand or dust, certain infections, certain vaccinations, even certain reactions to COVID vaccines. And factors that trigger cutaneous lupus include over 70 drugs, which are mostly used for high blood pressure, some proton pump inhibitors, some cancer drugs associated with certain forms of radiation and radiation therapy. So the microbiome is the bacterial makeup in your gut. And these gut bacteria in lupus activate T cells, which is a type of lymphocyte. And when you have T cell activation, you get more inflammation. So the whole gut microbiome connection with lupus is taking off. There were several papers in EULAR about can we control lupus with diet? And there are several areas that it is being looked at. So how can we halt the evolution of lupus? We can try to alter its genetic expression. We can deal with vaccines. Vaccines are a double-edged sword. Sometimes they can prevent lupus. Sometimes they can flare lupus. We can improve diet. We can eliminate environmental exposures. And when lupus manifests, it manifests in two ways: through inflammation, which is treated with, like, let's say, steroids and Plaquenil and anti-inflammatories. And it also affects the vascular system, which I'm going to get into. A lot of the papers at ULAR dealt with a new concept called omics. Omics is the collective characterization and quantification of sets of biological molecules and how they translate into the structure, function, and dynamics. And so we have what we call endotypes or subgroups. There are several omics initiatives in lupus from the NIH to other private centers. And the goal is to identify which lupus patients would respond to medications prior to administering them. In other words, if you have certain antibodies or certain lymphocyte subsets, we should give you pharmaceutical A as opposed to pharmaceutical B. And so this is what we call RNA-based precision medicine, where we have molecular endotypes or subgroups, where we are able to it's called personalized medicine or precision medicine, where we can predict whether you will respond to a specific treatment. So the targeted therapies in lupus, other than, we have general treatments for lupus like steroids that kill bad cells, but they also kill good cells. There are specific targeted therapies that just only kill kill bad cells, but don't kill good cells. These are targets for T cells, which is like Orencia that's on the market, B cells, which includes Benlysta, rituximab, complement, which includes a drug called Tavneos, cytokines, which are used for rheumatoid arthritis that block a variety of interleukins. The innate immune system, such as the block interferons, such as anifrolumab from one of our sponsors here at AstraZeneca, or block toll receptors. And there's tolerogens that promote immune tolerance. And there are also small oral medications that are oral that block small surface cell receptors, such as JAK inhibitors, such as Rinvoq or Xeljanz. So the immune abnormalities that are seen in lupus are listed here. And that's why it's so hard to find a good lupus drug, because we have like 10 things going on that are bad at the same time. We have T suppressor cells that act as T helper cells. We have cell signaling defects. We have cytokine dysfunction, apoptotic blebs on surface cells that are being killed. We have B cells making autoantibodies. We have defects in immune tolerance. We have innate and adaptive immunity issues that are separate, and something called netosis, which we're going to talk about. And the mitochondria of the cell also can produce cellular damage. So some of the new approaches to dealing with this include GLPs, which, how many of people in this room are on a GLP? Like Wegovy or, okay, a lot of you, and there's some evidence for that. Complement activation, interferon and netosis, and cellular therapies, which we have some sponsors here. So we know that there's a huge increase in GLP usage, and there is some evidence that these are anti-inflammatory. And GLPs act on the vascular system, immune cells, the kidney, the eyes, the bowel, the heart, the brain, and the pancreas. Now, about 20% of lupus patients also have Sjogren's, which is dry eyes and dry mouth. How many people here have Sjogren's? A lot of you. And the first drug in 25 years to come out for Sjogren's will be out in November or December. It's called ianalumab. But there are also several other papers that were presented at EULAR with 5 different agents that will help Sjogren. So we're going to see a lot of our patients being eligible for certain Sjogren's drugs that will come out in the next few months. I want to spend a little time talking about a poorly understood area of lupus, and that's the autonomic nervous system. I mentioned earlier that lupus can manifest itself as inflammation, and that's been known for a long period of time. But lupus also affects the autonomic nervous system. The autonomic nervous system controls your pulse and blood pressure by opening and closing vessels. An example of this is Raynaud's. Raynaud's is when you turn red in warm weather and you turn blue in cold weather, your fingers, your toes, the tip of your nose. And what's interesting about dysautonomia is that it's present in about 15 to 20%, if not more, of lupus patients, and it causes a lot of the symptoms that don't respond to anti-inflammatory therapies. And so we have the central nervous system, which is the brain and spinal cord, and we have the peripheral nervous system, which allows you to move your arms and legs and feel things. We also have the dysautonomia. So the dysautonomia causes palpitations, sweating, associated with mitral valve prolapse, cognitive issues. If you get too much blood flow to the brain, you can get a headache. If you don't get enough blood flow to the brain, you get a lupus fog. It's sort of, I call it Raynaud's of the brain. It can also affect gastric motility, and it can also promote bladder issues. So the causes of autonomic nervous disease are very highly variable. The most common cause of dysautonomia in the United States is diabetes. But from autoimmune with rheumatoid, lupus, scleroderma, and Sjogren's and sarcoid, you can also get a dysautonomia. It's often a complication of the peripheral nervous system involvement. So the therapeutic approach to the dysautonomias are often just sympathetic nervous system adjustments, such as cognitive behavioral therapy, biofeedback, prayer, relaxation techniques, breathing exercises, but in extreme cases, sometimes we have to go with rituximab or intravenous gamma globulin. Also, there's a group of people who have dry eyes and dry mouth who have been statistically associated with mast cell activation syndrome, POTS, or Ehlers-Danlos. Anybody in this room have any of those? Some of you. So the other thing that's an area of great interest is complement activation. And we now have 3 drugs on the market that deal with complement activation inhibition that are being studied in lupus patients. And through Exogen, which is a diagnostic lab that looks for different forms of complement activation, we can activate complement on our B cells, on our T cells, or on our platelets. And if we inhibit or block it, we make a big difference. So elevated complement activation is seen in mostly lupus, but also a certain percentage of patients with other autoimmune disease. I want to talk about interferon. Interferon is part of the innate immune system. It's a central driver of lupus pathogenesis, and it is triggered by endogenous factors in the environment, and it activates white cells and lymphocytes, and it drives a lot of the inflammation in lupus. We do have a drug on the market, anifrolumab or Safnello, that blocks T-cell interferon activation. There are several other agents that are being looked at through something called plasmacytic dendritic cells that promote the release of interleukins that promote the release of interferon. And also blocking interferon will play a major role. In the New England Journal of Medicine last week, there was an article on the first drug that was tested to block something called NETs. In 1948, the LE cell prep was the first blood test to look at lupus and identify lupus. And the LE cell prep was essentially a net or a neutrophil extracellular trap. It's a meshwork of fibers that sort of trap immune complexes and activate them and promote inflammation. For years, people have tried to address this issue. However, when we can't clear nets, they can deposit in tissue and promote inflammation. And it can lead to activation of the immune system. So there's a chemical called DNase, which destroys DNA. And by using a DNase, we can block the activation of nets. And there are 2 companies that are working on this. One is from Andy Rife, who some of you may know. He was at Children's Hospital of Los Angeles for about 20 years. He ran the program there before he went into industry to work on this drug. And it was his company that had the article in the New England Journal of Medicine 2 weeks ago, where they were able to show dramatic, and I mean really dramatic, response in the first patient that was studied. It was also presented at the ACR as a plenary session presentation. Also, one of the other lupus advocacy organizations in New York has also invested in a net company that is studying this as well. So we're going to be seeing this as the new, in 5-10 years, as the new treatment for lupus. And this was presented at EULAR, and it's very, very exciting. Then we get to cellular therapies. Cellular therapies historically was stem cell, and the mesenchymal stem cell trial has been going on for 10 years, funded by the LFA and the NIH, and it's about complete. And I think the responses that we're going to see are modest, but it's still an advance, but it's not something that's ever going to take off. And then we get to cellular therapies, which is CAR T, and there's a Fate booth here. And Fate is a California company that actually, I don't know how many of you Remember, there was a proposition on the ballot a few years ago where to fund stem cell and cellular therapy research that passed, and Fate was the recipient of the largest amount of money, meaning that they were the most promising group. And our group is going to be starting our first patient on this agent in the next few weeks. So this is where we literally give the patient a completely new immune system by getting rid of the immune system they have and substituting a new immune system. I'm not going to go through it in detail, but suffice it to say that at any given clinic visit, 15 to 20% of patients have a lot of lupus activity, and most of them, 80% of those, will respond to aggressive therapy. But the 20% of the 80% of the 15% are eligible for cellular therapies, which is only about 3,000 or 4,000 people in the United States. But for those, it could be absolutely life-saving. So Fate, which is, has a table here, and you can find out more about it, uses an off-the-shelf therapy that can be done as an outpatient, and it can be done, it is being studied in numerous conditions, especially lupus and lupus nephritis. So I think I've talked about some of the other things, and just wanted to say this is an extremely promising time. There's new approaches to diagnosing and managing lupus that have evolved that will lead to new treatments over the next few years. So with that, we're going to have a 3 or 4 minute break where you do your questions and answers, and you have an index card, and then I will start to answer them. Thank you.
If anyone has a card, you can just hold it up and I'll come around and collect them. Thank you.
Anybody wants to stretch can stretch.
Yeah, and if any questions come up as we answer it, feel free to just hold up your card and I'll come around. We'll start with those.
Why do our teeth break down over time? A lot of lupus patients have Sjogren's, which is dry eyes and dry mouth, and they are more prone to dental caries and issues which would cause dental decay. They're also more prone to gum infections because they have an altered immune system. Can you explain how hot weather changes influence flares and fatigue and headaches? Well, it doesn't matter whether it's hot or cold or wet or dry, but what you need to know is that changes in barometric pressure can flare lupus. If it goes from hot to cold or wet to dry, the body is more aware of it. So it's the change in the barometer. So if you fly to a different part of the country or the weather changes from humid to dry, you are more sensitive to it. What are the pros and cons of hormonal therapy in menopause for those with lupus? Well, you're going to be hearing from Dr. McMahon about women's health in a few minutes, but let me suffice it to say that the amount of estrogen and estrogen replacement therapy is only 1/5 of the amount of estrogen in a birth control pill. So the amount is very, very small. And while there have been a few articles in the world's literature of flares from estrogen replacement therapy, it is extremely uncommon, and there's no reason why most people who don't have severe migraines or have antiphospholipid syndrome cannot have this. Does a vegan diet help with lupus? Is eating gluten-free helpful with lupus? Well, 20% of people with one autoimmune have a disease have a second autoimmune disease. And celiac disease is a autoimmune component that's seen maybe in a small percentage of people with lupus. And I'm not, it depends with you're talking about a vegan diet, how much protein there is, and the whole microbiome with lupus. There are some mice that we give hypomethylated diets to methylated diets to that help them because they're hypomethylated when they try to repair DNA that's broken. The answer is we know that fish or fish oil is good for you. We know that alfalfa sprouts are bad for you, but other than that, there will be some diet for lupus in the next few years that we don't have. Is there a clinical trial for CAR T at your clinic or office? My answer is yes, I do have one. And I believe Dr. McMahon can address that, whether there's one at UCLA or not. How can you find out if you're eligible for a trial? You have to have serious organ-threatening lupus that has been resistant to immune therapies such as Cellcept, Cytoxan, Imuran, methotrexate, Benlysta, Safnello. Okay, yeah, we have more cards. I'll trade you.
Question from our online audience.
Yes.
Yeah, we actually have a few questions from the online audience, so I'll just dive right in. In seronegative Sjogren's, how do you assess possible CNS involvement when there is progressive cognitive decline and acute neurological symptoms, but standard testing is largely non-diagnostic?
Okay, 30% with Sjogren's are SSA or SSP negative. There is something called an early Sjogren's panel, which is controversial and sometimes is helpful. But the way to diagnose central nervous system Sjogren's is by imaging and a lumbar puncture. And but there's a lot of what we call autoimmune ganglionopathy, which is also diagnosed through certain biopsies and small nerve fiber, et cetera. But it's a major problem.
And can
Okay.
I just ask a quick follow-up to that question as well?
Yes.
What findings or clinical pattern would make you feel treatment should not be delayed when the evaluation continues?
Well, in Sjogren's, there's inflammation where if you have a high SED rate, a high CRP, a high white count, or a very low white count, you need anti-inflammatory treatments. But all too often, a lot of the issues in Sjogren's deal with the vasculopathy that I mentioned that is currently being addressed that does not respond necessarily to anti-inflammatory treatments. Although at the Mayo Clinic and at Scottsdale and Rochester, there's some work being done with IVIG in combination with rituximab for these patients. Okay, is Benlysta and Safnello infusion, if they result in, okay, if you're allergic to Benlysta or Safnello, what can you take? Well, if you look at the American College of Rheumatology guidelines, we often we can use biologics as first line. We can also use mycophenolate, methotrexate, azathioprine, steroids. We can use hydroxychloroquine. We can also use drugs that are on the market but not approved for lupus, such as antibodies to interleukin-6, T-cell blockers such as abatacept, and we can also use rituximab. And more recently, obinutuzumab has been approved, and sometimes calcineurin blockers such as voclosporin are now approved for lupus nephritis or tacrolimus. Okay. Do I think that GLP-1 will ever be FDA approved for autoimmune and lupus? I have no idea. I don't think that any of the pharmaceutical companies are actually studying this at this time. but they are anti-inflammatory. There's been a few papers suggesting that, let's say, osteoarthritis of the knee responds to it. Okay, so how effective do I believe in ianalumab will be for Sjogren's and lupus? So ianalumab is a biologic from a company called Novartis that has been fast-tracked by the FDA for Sjogren's, and they're supposed to make a decision in November or December whether it will be on the market. And it is very similar in what it does to Benlysta. It's modified a little bit. There are two types of Sjogren's. There's glandular and extraglandular. Extraglandular Sjogren's is when you have heart, lung, kidney, liver, brain, or bone marrow involvement, and that is serious, and that's seen in 15% of all Sjogren's, and this will be a good drug for that. However, for just glandular Sjogren's, where you're tired and achy and dry, I think it's probably too strong. Ianalumab is not being studied for lupus that I know of. There's also a telatorecept, which is a Benlysta-like drug that blocks the same cells that Benlysta does, but also has a second mechanism of action that is FDA approved for lupus in China and in about 20 other countries. And it is being studied in lupus, and it's also in a phase 3 trial for another company called Vor for Sjogren's. Mia?
We have a few more online. One is, what are potential causes of muscle atrophy and loss of strength that does not show up in blood tests, EMG, or brain MRI?
The most common cause of atrophy is deconditioning. The second most common cause is corticosteroids. There are certain medications that can also cause muscle atrophy, or if you were inflamed and it healed with a scar, that can cause muscle changes.
And one more, what medications are good for older lupus patients who cannot use Fosamax for osteoporosis? Vitamins, injections, and are there any problems with the injection process?
So what drugs are used for older people?
Older lupus patients.
I'm sorry, older medication. I'm sorry,
Older lupus patients.
Yes. Sometimes with older lupus patients, we give them a very low dose of prednisone, like 5 milligrams a day. And we also work with their bone health at the same time. But Benlysta and Safnello are probably really safe in older lupus patients as well. Okay. I have one here. Why is it difficult to diagnose lupus when I have the butterfly rash? Because there are many causes of butterfly rashes. The most common cause of a butterfly rash is rosacea, which is a form of acne. You can also get a butterfly rash from something called polymorphous light eruption. One way to just differentiate it is that in lupus, the butterfly rash spares the nasolabial folds, whereas in these other conditions, it does not. Also, if you're using a lot of cortisone cream for a rash on the cheeks, you can get a lot of cutaneous atrophy or telangiectasias from that. Can a patient with lupus get radiation therapy? The answer is most lupus patients can get radiation therapy. However, there is some patients with lupus, a small percentage, have something called interstitial lung disease. And if they have interstitial lung disease, which is, they should probably not get radiation therapy because it can make the interstitial lung disease worse. Does anybody in the room have a question that they want to raise their hand and ask me?
Mia, you have something in the back?
I have a few more online if we're okay with it.
Okay.
Yeah, one of them is, how can you distinguish between behavioral issues in lupus fog and behavior due to other diseases such as Parkinson's?
How can you distinguish between lupus fog?
Lupus fog and other behavioral symptoms related to Parkinson's, say.
Okay, so Medications given to treat any condition can cause behavioral abnormalities. Normal people can get anxious and depressed. And lupus can also inflame the brain, but inflammation of the brain is very unusual. And also those who have had inflammation of the brain over a period of time can developing scarring and atrophy. And steroids can also cause a cortical atrophy. So there are many different things that can do that.
I can ask a few more. This one's anecdotal, so bear with me. I am a newly diagnosed patient with lupus. I had excess protein in my urine sample over a month ago. I finally got a nephrology referral after requesting one. Should I be worried about severe kidney damage in the time it takes to get to my appointment next month?
Most patients with lupus in the kidney evolve it slowly, but there is a group of people that develop it rapidly. It depends on quantitation of the protein. If it's over, let's say, 1,000 milligrams, you probably need prompt attention. Diabetes, amyloid, a whole bunch of streptococcal infections, a whole bunch of other conditions can cause protein in the urine. You can also get protein in the urine if you are an overachiever and do vigorous marathon running and athletics. So it's it depends.
Any other questions just coming up?
Yes,
Yeah, I have lupus and Ehlers-Danlos.
yes.
But beside that, sometimes I feel stinging or like something's biting me down my leg or arm and or something's crawling on me and there's nothing there. Who should I see for that?
Well, you should start with your primary care doctor, who should do a complete evaluation. And if they want to send you to a neurologist, that's the correct person to see.
Any other questions in the room that are coming up or online, Mia?
Yes, you have a question?
Oh, is there a question over here? I'm going to bring the mic to you, if that's okay, so that everyone can hear your question.
And we have a question here.
Good morning. It's so good to see you again, Dr. Wallace. I have developed interstitial lung and disease. So I want to know, could you elaborate a little bit more about that, simply and
Okay,
without going
so
all the way
So
in?
the lung and lupus can be affected in many different ways. There's pleurisy, which is the lining of the lung. There is pulmonary hypertension, which is vascular. You can bleed into the lung, called pulmonary hemorrhage. You can develop a whole host of less common abnormalities, but interstitial lung disease can be acute inflammation or it can be a chronic low-grade inflammation. Interstitial lung disease usually evolves over many years. It's associated with lupus overlap syndromes, with mixed connective tissue disease and scleroderma. It's also associated with Sjogren's. It's usually identified by a high-resolution CT scan of the chest. Sometimes with the main issue with interstitial lung disease is whether or not you have active inflammation or whether it's scarred down. Because if it's active, then it's reversible with usually a combination of steroids and Cellcept, sometimes rituximab, sometimes antibodies to interleukin-6. If you are scarred down, then it is much harder to treat. Also, there's ground glass, which suggests more activity, or honeycombing on the appearance of the imaging, which is more scarring. What is a common cause of chest pains in lupus with a normal chest x-ray? One of our fellows about 10 years ago, who now works at UCLA, wrote a paper where she looked at all the reasons why somebody came to the Cedars emergency room for chest pain. And she found that that lupus patients, for lupus patients, chest pain was the most common reason why a lupus patient went to the emergency room. The most common cause was either pleurisy or costochondritis, which is where the sternum connects to the rib through a tether-like, rope-like ligament. So you need to, if you have chest pain with lupus, you need to rule out heartburn or esophagitis. You need to touch the area around the sternum and see if it's painful. You need to see if the patient has difficulty breathing or pain on breathing, where it could be a scar in the pleura or active pleurisy. Yes.
I'm going to come to you with the mic.
Jumping off your mention of costochondritis and, kind of these issues surrounding the ribs, if there's inflammation in that area, and I don't know if other people have experienced this, but I've experienced, especially the lower two ribs slipping, which is very annoying. What can we possibly do?
For costochondritis, well, the first thing I do is give nonsteroidals like Advil or Aleve. If patients have an issue with that, I have them use Voltaren gel, which is over the counter. You have to remember, whereas Voltaren or Advil is 100% absorbed, Voltaren gel is only 6% absorbed, so you don't have to worry about the stomach with it. You could also use Aspercreme or Bengay. You could use lidocaine. You can use CBD. And if it's a major problem, sometimes I send patients to our pain center with an anesthesiologist, where they can actually inject cortisone into the costochondral margins. Oh, here. Okay.
Oh, you have one there first? We'll do this.
No, I did that.
Oh, yeah, I thought you did. So I think we have one more question over here.
Yes.
Good morning. Why can I not sit crisscross when I have lupus?
Why can you not what?
Sit crisscross or put pressure on my legs.
I don't know. It could be structural, it could be arthritis of the back, it could be arthritis in the hip, it could be avascular necrosis of the hip, it could be a muscle issue, it could be related to your body mechanics or posture. There's many different reasons. I would probably start with an orthopedist.
Well, thank you so much. We're going to wrap up this first session. Thank you so much, Dr. Wallace. Our next speaker is going to be in about 10 minutes, so we're just going to take a quick break, run to the restroom. Please visit our booths, get some refreshments, and then we'll meet back here in about 10 minutes. Thanks so much. Okay, I hope everyone had a nice little break. Hi, I'm Maggie. I'm the virtual care coordinator for Lupus LA. I know Susan told you a little bit about my services. I'm here today if any questions come up, or give me a call. It's my pleasure to introduce Dr. McMahon, and she is a member of our medical advisory board and also a rheumatologist here at UCLA. So I'm going to let her take it away. Thanks.
Thank you, everybody, and thank you for being here on a Saturday morning. It's nice to spend the Saturday with you. Today, we're going to cover women's health issues. Aside from pregnancy, I know there's been some relatively recent pregnancy talks, and pregnancy could be a whole topic we could cover for hours in and of itself. But if you do have some burning pregnancy questions, we can answer those in the Q&A. So what are the current recommendations for that pre-pregnancy time when you're trying to avoid pregnancy and using contraception? So a lot of the data that we'll be talking about today comes from these two overall guideline recommendations, and in particular, the 2020 American College of Rheumatology guidelines for the management of reproductive health. So that covers everything from, avoiding pregnancy with contraception to treating menopause. Now, I will take a step back and say that there's very little data that's been actually studied in lupus patients. We'll kind of talk about the studies that are really strong, good studies that we do have. But a lot of the things that we'll be talking about come from either kind of our best evidence, but not those gold standard studies, or even just recommendations that we kind of gather from the general population. So when we have that really good, strong data to give recommendations, those recommendations are going to be considered strong recommendations. A lot of the other recommendations that we have for or against will be, conditional recommendations, again, with the caveat that they haven't particularly been studied in patients with lupus, but we'll kind of go over that. So right about the time when I was getting started in lupus, there are a couple studies that we'll talk about that I think were actually really important and gave us a lot of good information. But, back about a little bit before the time when I was actually learning to be a rheumatologist, as you know, there's probably a really strong role for estrogen in lupus because we know that lupus has such a strong predominance for women. So there's got to be some role that estrogen plays. And so because of that, I think there were a lot of rheumatologists that were very afraid to allow their lupus patients to go on any oral contraceptives that contained estrogen or any kind of hormones. But there were a couple studies that were done during that time that I think were very important for us to kind of understand the risks for patients in lupus. So this was a study that was done. It was published in 2005, but we actually had a lot of patients, maybe some of you even participated in this study at UCLA. But it looked at the safety of using contraception in patients with lupus. And I think actually even a little surprisingly, we found that there's really not an increased risk of severe flare in patients with lupus when they use hormone-containing contraceptives. Now, there are a couple of really important caveats to that. Patients who had antiphospholipid antibodies, because that increases risk of clots, of course, and we know that estrogen can increase risk of clots, any patients who had antiphospholipid antibodies were excluded from these trials. And they also excluded any patients who had really severe lupus. So anybody who had a really active kidney flare or was having, any kind of severe lupus flare was not included in this study. But for patients who are kind of going along, your lupus is relatively stable or a little bit of disease activity here or there, starting on a hormone-containing oral contraceptive actually does appear to be safe and does not seem to cause any severe flares of lupus. So that was really important information for us to have to be able to help, make decisions together. So of course, there are other ways of thinking about long-term contraception planning, and some of that is using some of the assisted reproductive technology. And there are some patients who, may be starting on a new therapy and want to think about egg donation, or others who are using assisted reproductive technology to get pregnant now. There are actually some guidelines that I thought maybe didn't get covered in the pregnancy talk that might be helpful to just kind of touch on here. So like a lot of the things that we're going to be talking about, we think about contraception and pregnancy planning. I'm sorry. We're still talking about contraception and pregnancy planning. So again, when we think about this, we want to think about dividing this into whether you have any antiphospholipid antibodies or whether you don't have any antiphospholipid antibodies. So again, if you have antiphospholipid antibodies, then we really don't want to think about using any kind of hormone contraception or any hormone therapy. And that's considered to be a relatively strong, indication, again, based on all the evidence that we have that can really increase risk of blood clots. Now, they do give a little bit of information here that we won't really touch on about patients who have other rheumatic diseases. But if your lupus is relatively mild, you really have all the different contraception options open to you. And we'll touch on those a little later, but that includes hormone-containing contraception. And that's a pretty strong recommendation, again, based on that strong study that we had that was done in lupus patients. Now, there's a recommendation if you have lupus and your disease is really active. Again, because those patients were excluded from those original trials with the hormone contraception, there's a suggestion that you may want to avoid any hormone-containing contraception. If, say, for instance, if you have kidney disease that's active, you may want to go to some of the other forms of contraception. And then we'll talk about some special circumstances also. So let's talk about the recommendations for patients who have antiphospholipid antibodies. Again, this comes from those 2020 ACR guidelines, where there's a strong recommendation, again, that you avoid any estrogen-containing or progesterone-containing contraceptives, because we know that increases the risk of blood clots. So there's a strong recommendation to use an IUD, and you can have the IUDs. It is considered safe to have the IUDs that do have a little bit of hormone in that IUD, because that mostly stays localized. So those are considered safe. Or you can use a progestin-only pill as long as there's no estrogen contained in that pill. That's considered safe as well if you have antiphospholipid antibodies. Now, that is even if you have antiphospholipid antibodies but don't ever have a blood clot in your past. So when you're talking about contraception with your rheumatologist, that's one of the things that likely he or she will want to check, is if you have any of those antiphospholipid antibodies present. Again, here's a little bit of other recommendation from the CDC and the World Health Organization. Very similar. Again, you don't want to use any estrogen-containing, as we've been talking about. There's also a mention that if you use something with like a estrogen-containing patch, that actually has a higher concentration of estrogen. So that would even be a higher risk, or considered to be higher risk for patients who have those antiphospholipid antibodies. So in this circumstance, those estrogen-containing patches are also not considered to be safe. But again, IUDs are recommended. Now, what about if you're taking mycophenolate? So we've already talked about if you're taking mycophenolate because you have really active kidney disease, that might not be the time to be taking a hormone-containing contraceptive. But mycophenolate, there's a couple other things to keep in mind, because we use it for lots of reasons in lupus and for other indications. And maybe you've been on it for a long time and things are stable. But it's important to recognize that when you're on a hormone-containing pill and mycophenolate, the mycophenolate can reduce the efficacy of the oral contraceptive. So they just might not work as well in you if you are taking mycophenolate. So that might be another reason to decide to choose another form of contraception or to use multiple different forms of contraception when you're taking that mycophenolate. So here's kind of a busy chart, and we're not going to necessarily go through everything, but I thought it was actually kind of helpful. And if you want copies of these slides, I'm happy to share them with you so you can kind of use this for reference. But it's important to also think about, when you're thinking about contraception, how effective is this contraception? Because of course in lupus, we always like to, carefully plan pregnancies for a time when things are quiet and you're ready to approach that and be off all the wrong medications and be on the right ones. So you want to make sure that you're using effective contraception. So you can see over on the end the rate of failure. So the IUDs, whether it's copper or the hormone-containing IUDs, are really considered to be very effective with a less than 1% one-year failure rate. So that's something else to keep in mind when you're choosing your form of contraception. Also considered effective, but not quite as effective, are progestin-only containing pills. You have to be a little bit more careful if you don't take them regularly. If you miss a few days, they lose their efficacy. So if you're good at being really consistent, they can be pretty effective. But again, that one-year failure rate, again, probably because most of us forget to take a pill here or there, is up to 5 to 8%. So less effective than some of the other things that we've been talking about. Now the Depomedrol injection, every 12 weeks, that's, you don't have to remember to take anything. You don't have to do anything. That can be effective. It's about a 3% one-year failure rate. And again, it's safe in most patients, but we want to use that with caution in patients who have antiphospholipid antibodies. And usually we don't consider it as first line in those patients. A couple other things to think about. The transdermal patch I already mentioned has actually a little bit of a higher dose of estrogen. So we tend to shy away from those even in regular lupus patients just to avoid that higher dose and avoid any extra risk. And then finally, some of the more barrier methods. Certainly it's safe from a lupus perspective. They won't cause any flares, but it's important to remember that things like diaphragms and condoms do have a higher failure rate, 12 to 18%. If you're using spermicide alone, that can even be up to a 24% failure rate. So important things to keep in mind. Sometimes combining those together can improve the efficacy overall. So now here is the slide that I was talking about earlier when we think about assisted reproductive technology. So again, sometimes patients will come to me and say, I'm interested in freezing my eggs so that I can plan a pregnancy down the line. Sometimes you've been trying to get pregnant and having a hard time getting pregnant and want to use assisted reproductive technology. Of course, that usually involves giving hormones to stimulate egg release. And of course, that can cause flares in lupus patients. But it can be safe and safely done in lupus patients as well, as long as we, adhere to certain, guidelines or recommendations. So generally, we always want to, think about both pregnancy and trying these assisted reproductive technologies in patients who are stable. So when you're in the middle of a bad flare, if you've just developed nephritis, that's not really the best time to be thinking about this. And generally, we would want to avoid giving you any extra hormones that could stimulate, a flare or worsen disease. But assuming that disease is pretty stable and you're doing okay, again, when we think about other additional precautions, we think about whether you have antiphospholipid antibodies or not. Now, even if you have antiphospholipid antibodies, it doesn't mean that you absolutely can't do this, but oftentimes we'll actually recommend that during the course of the procedure or while you're receiving the hormones, that you actually are treated with a blood thinner like low molecular weight heparin injections just to avoid any increased risk of blood clots that could occur. And otherwise, I think that's the major thing that we kind of consider. Now, certainly in patients who have previously had pregnancies and have had pregnancy losses that have been associated with antiphospholipid antibodies, those patients, we definitely recommend that prophylactic anticoagulation with the low molecular weight heparin shots. And certainly similarly, if someone has antiphospholipid syndrome. So again, we've had a lot of patients who have gone through these procedures and technologies, but it really requires close coordination between the OB doctors and your rheumatologist as well. Okay, so this is a patient who came into my office last week, actually. She's 53 and she's had lupus since she was 20. Initially, back when she was 20 years old, she had kidney involvement with lupus nephritis. For many years, she was treated with mycophenolate and hydroxychloroquine, but she's actually been doing really well over the last 10 years and has not really been having any lupus symptoms, no lupus flare symptoms. Her kidneys have been doing great, and we were able to taper her off her other medicines. She was on hydroxychloroquine alone. But she comes to my office and she says, I think I'm having a lupus flare. I've been having a lot of fatigue. I'm having a really hard time sleeping at night. I have sweats that wake me up in the middle of the night. My joints have just been hurting me. I'm aching everywhere, a lot of joint pains. I'm feeling stiff. I'm having a lot of brain fog. I'm having a hard time remembering, words and remembering what I was supposed to be doing when I walked into, one room. I don't remember why I walked in there. So I think I'm having a flare of my lupus. So how many of you think she's having a flare of her lupus? I mean, it's context clues. It is a talk on, women's reproductive health issues, but certainly there are other things to think about, as we'll discuss. I mean, I think certainly something like menopause can masquerade, I think, as many lupus symptoms. I think there's really a lot of overlap, as we'll discuss. So menopause, what is menopause? So menopause is when you permanently stop having periods, and that's because you're not having that egg release from ovarians, the follicular activity that kept your periods going for all those years. So typically, menopause will happen between the ages of 45 and 55. On average, most patients in the general population have their menopause around the age of 50, 51. You can have premature menopause before you're 45, or late menopause even after the age of 55. Now, remember, in lupus, there are a lot of reasons why you may have premature menopause. So sometimes we have to think about this even at earlier ages. So lupus itself can attack the egg follicles, and so you can have premature ovarian failure. Sometimes some of the medicines we use for lupus can cause premature ovarian failure, especially if you've been on things like cyclophosphamide or strong medications in the past. So sometimes these are issues we start dealing with even at a much earlier age than in the general population. So how do you diagnose menopause? Well, if you're over the age of 50 and you've not had a period for 12 months, that's it. That's considered menopause. So you don't even have to have the hormone blood tests. That's just considered menopause. But for those who are below 50, or if we're just not sure, or if you're in your early 40s with lupus and start having some of these symptoms, you can do a blood test and test hormone levels. You can look at the FSH levels, and if they're high, then that can also indicate menopause. So, when you look at some of these symptoms associated with menopause, I could give a different talk and put the same slide up with the same symptoms, and you might think it's lupus. So there's such an overlap between lupus symptoms and menopause symptoms. So vasomotor symptoms, psychological symptoms, including anxiety and depression, lots of sleep disturbances. You can have sexual dysfunction. Cognitive symptoms, brain fog can be kind of very similar in lupus as in menopause. Joint symptoms, osteoporosis, cardiovascular disease. These are all things I talk about when I talk about, risks associated with lupus. And so, again, I think it's important to have good ongoing conversations with your rheumatologist to try to help sort out, some of these symptoms and figure out, what's lupus, what's menopause. And sometimes it can be a little bit difficult to tell, but we'll talk about that as we go along. So a lot of what I'm going to talk about now is really more based on the general population. There's not a lot of data out there. In fact, when I looked up lupus and menopause, there's very, very few studies that have been specifically done in menopause and lupus patients. So again, a lot of this is kind of taken from what we know in the general population. Even in the general population, there's not nearly as much research out there as really, I think, needs to be done to help us understand menopause. But we know vasomotor symptoms, those are probably the most common symptoms you hear about when people talk about menopause. Hot flashes, obviously, I think we've all kind of heard of hot flashes. They can be experienced by up to 85% of women in menopause. Most of the time, this will last for less than 5 years, but there are some patients who can have, about 25% of patients that can have those symptoms that keep going for 5 years, 10 years, or even beyond. So, sometimes they are easy to manage and sometimes they're a little bit tougher. And there's even been some studies that, it's important to kind of note these symptoms because it may be in patients who have very severe vasomotor symptoms that you can actually even have an increased risk of cardiovascular disease. So again, just something to keep in mind. They're not necessarily completely benign. Now, joint symptoms in menopause, up to 70% of women can have increased musculoskeletal joint pain and stiffness. And there's, again, not a lot of data on this that I could find, but we do know that estrogen receptors are present on bone, the cartilage in joints, the lining of joints, the synovial lining, tendons, and muscles. And so it's thought that that loss of estrogen, makes the tendons and joints a little bit more stiff. That may be why we tend to see that osteoarthritis and the other kind of general forms of arthritis increase as patients get older. And so when you're thinking about, is this more of a menopause-related symptom or more of a lupus-related symptom, kind of go back to when you first presented with your lupus and when you were talking about some of your joint complaints. So if you're having joint stiffness in the morning that lasts for more than 45 minutes, but tends to get better when you're walking or using your joints, many times we think of that as more of an inflammatory symptom that might be more related to your lupus. If you have a lot of swelling in a joint, a lot of warmth and inflammation, that can also kind of be a little bit more of a lupus symptom, as opposed to, the joints that hurt more, or the tendons that hurt more when you use them. They hurt more at the end of the day. You kind of have some stiffness, but that usually goes away after a few minutes. Those might be the more of the menopause or the aging-related kinds of arthritis. So again, you can sort this out with the help of your rheumatologist and your other doctors, but it can be a little difficult to kind of sort out what's what. And certainly we don't want to be immunosuppressing you or giving you steroids or even, other things if it's not really an inflammatory pain. Now, another important to think about is that it's common in aging and even more common in lupus patients to have a loss of muscle mass as we age. And that's called sarcopenia. And we know that women with lupus are at higher risk of this. So that loss of muscle mass and that decreased strength, of course it's inconvenient, but it also can really lead you to be frail, have more of a risk of falling, and have more of a risk of fractures, et cetera. So as we'll talk about, it is important to keep exercising and try to keep your strength and muscle mass up. So psychological and cognitive symptoms, depressed mood, anxiety, irritability, mood swings, lack of energy, those have all been reported in the general population with menopause. I don't have any data for what that is like in patients with lupus, but again, a lot of times those can be, more common in lupus patients as well. So one would imagine that that would certainly be an issue with lupus patients with menopause. About 40% of women with menopause report difficulty sleeping. But overall, when you look at the general population, most women don't experience major depression or major mood swings. So a little bit of irritability, but not major changes in depression and anxiety. Again, we don't have data on that for lupus patients. Sexual dysfunction can be an issue. Again, there's a lot of things that can go into that, but estrogen deficiency can lead to vaginal dryness and pain. And in women with lupus, that can certainly be compounded by Sjogren syndrome as well. So again, those are issues that can be discussed and addressed, but don't be shy to bring those up with your rheumatologist and talk about those things as well. So osteoporosis, again, that's kind of its own talk. But just to keep in mind, even in the general population, it's very common after menopause, and certainly loads of reasons on top of all the general population reasons why lupus patients are particularly prone for osteoporosis, especially if you've been on corticosteroids in the past. Some of the things that we've already talked about, like having to use things like heparin or low molecular weight heparin while you're pregnant, can also increase bone loss. So if you've had any of those things in the past, in addition, vitamin D, if you're doing what I tell you and staying out of the sun, you also have lower levels of vitamin D, which can lead to bone loss. So lots and lots of reasons why lupus patients can be even at higher risk of osteoporosis. And so it's important to remember to get screened for that. And you can work with your rheumatologist if you haven't had a test to look for your bone density. And of course, the reason why we are worried about that is because we really want to prevent fractures. And so that's what really all of our treatments for osteoporosis are geared towards, is preventing that. So I know I've talked to this group before about cardiovascular disease. It's one of my interests in lupus, because we know that there's an increased risk of cardiovascular disease in lupus. And a lot of the data that I'll cite is, we know that women between the ages of 30 and 45 have up to a 50 times higher risk of cardiovascular disease. That's one of the statistics that we always cite, because we do want people to recognize that even young women are at risk for cardiovascular disease. But that being said, the most common group that has cardiovascular disease, even in lupus patients, are older patients. So, increased age is still a risk in lupus patients, maybe not as dramatically different from the general population, but certainly when you look at numbers, it's still older lupus patients who tend to have more of these cardiovascular events. So again, important to think about screening for this, important to think about controlling any risk factors. Certainly if there are things that you control, like smoking, exercise, getting control of your blood pressure and control of your cholesterol, it's even more important as a lupus patient to try to get control of those things. And again, menopause is still going to be an increased risk in lupus patients as well as in the general population. Okay, so when I talk about a lot of the strategies that we have to control menopause symptoms, again, 95% of this is from the general population and not in lupus-specific studies. But in the general population, we know that there are things that can help. When we think about non-medication things that you can do, as with everything, exercise is always helpful. It's going to be good to manage, most of those symptoms, including the joint symptoms. You want to make your muscles strong. The exercise has also been shown to help some of the night sweats and some of the vasomotor symptoms. Yoga and meditation have also been shown to be able to help those vasomotor symptoms. So if you can't take some of the other medications to control those, yoga, meditation are strategies that you can try to use to control them. Cognitive behavioral therapy, which is kind of working with the psychologist to manage symptoms, they've also done some small studies that show that can help manage the vasomotor symptoms without any other medication use. Certainly dietary changes, always important to eat a healthy diet. Sugar is one of the triggers that can actually make joint pains worse in everybody, not just lupus patients. But so, avoiding sugar can really be something that, even that alone, I've had some patients who just cutting out extra sugar has helped a lot manage their joint symptoms. And then, of course, there have been some studies that show that smoking can make the vasomotor symptoms, the night sweats, that can make that worse, in addition to all the other problems with smoking. Alcohol, caffeine intake, spicy food, those have all been things that can sometimes make the vasomotor symptoms worse. So if you're really suffering with that, you may want to cut those things out of your diet. And then again, as I mentioned, smoking several times can also make even depression worse. So again, just another plug if you're still smoking. So there's one study specific to lupus patients that was done, and this was done back in the early 2000s, again, about the same time as the study that looked at the safety of oral contraceptives in lupus patients. There was also a study that looked at hormone replacement therapy in lupus patients. And so at that time, you may remember, if you're old enough like me, that, you know, prior to the early 2000s, everybody was getting hormone replacement therapy because we knew that it could, or we thought that it would prevent heart disease and osteoporosis in women. But we still weren't sure about whether this would be safe in lupus patients because of all the things we talked about earlier. So they actually did a study in patients, and in this study they found that there maybe was a little bit of an increase of mild or moderate flares, but no increased risk for severe flares. So overall, it's felt that it's pretty safe in patients with lupus to use hormone replacement therapy. Now, several caveats to talk about. Same kind of problems that we talked about with the other study. This study did not include anybody who had antiphospholipid antibodies, did not include anybody who was having a severe flare at the time. So this only applies to stable lupus patients who don't have any don't have any antiphospholipid antibodies. But in those patients, I think you can safely use hormone replacement therapy without being afraid of a severe flare. Now, right after this study, or right around the time this study came out, and after this, you know, most of the patients had already enrolled in this study, we had a big, you know, shift in the way we thought about hormone replacement therapy because there were two studies that were done in the general population at the time, the Women's Health Initiative and the Nurses' Health Study. And these studies were done because, you know, as I mentioned, we were using hormone replacement therapy in everybody because we thought it would help heart risk, since older women got, you know, younger women were protected, older women were getting heart disease, also again to protect bones. But there was a major surprise when they got the results of these studies because they actually found an increase in breast cancer, an increase in blood clots, and an increase in heart disease that kind of took everybody by surprise. And so we made a major shift. Nobody was then getting hormone replacement therapy for menopause. Now, when they went back and really thought about these studies, analyzed them further, they really did find some nuances to some of that data. So they found that some of the timing of the hormone initiation really seemed to make a difference. So in those studies that I mentioned, they would let anybody start the study. So you could be 85 and not on hormone replacement therapy yet, and you could enter the study. And what they actually found when they went back and looked at the data is if you started hormone replacement therapy within 10 years of menopause, those patients did not seem to have that increased risk of heart disease, and the risk seemed to be about normal. And actually, maybe even there was a little bit of a decreased risk of heart disease in patients who started that, maybe even a decreased risk of mortality. But if you started after 10 years, then that's when you started to see some of those heart disease risks. So that's why you may hear now that, you know, the general population, it's recommended maybe to start hormone therapy if you're going to start it within 10 years. But after 10 years, they usually discourage starting hormone replacement therapy at that point. And they also found that if you used it for a few years, but not for, you know, perpetuity, that your risks were also lower. The breast cancer risk, they found, again, if patients had a high risk of breast cancer, that seemed to be more a risk. If they had a family history of breast cancer, that was also more a risk of developing breast cancer. And when you looked at the breast cancer risk, you know, yes, it was increased. But if you took 1,000 patients and used hormone replacement therapy, and again, general population patients, that increased risk would be 5 patients out of 1,000 would have an increased risk of getting breast cancer. And if patients no longer have a uterus and use estrogen-only pills, then that risk was not increased at all. So again, a lot of nuances with this, a lot of data to talk about with your doctors and see how it applies to you when you're making choices about whether hormone replacement therapy would be a safe choice for you or not. But we do have a little bit of guidance from the American College of Rheumatology. This goes back to those guidelines that I mentioned. So again, if you have a history of antiphospholipid antibody syndrome and you're on anticoagulation, there's a conditional recommendation that you should not get hormone replacement therapy. Although in certain circumstances, with a lot of knowledge about potential risks included, maybe you could think about it with a lot of discussions with your doctor. But there's really a strong recommendation not to go on hormone replacement therapy if you are not currently anticoagulated and you have positive antibodies. Now, in some patients, maybe they had antiphospholipid antibodies 30 years ago, but if you look now, those antibodies are actually gone. There's a conditional recommendation that maybe it's okay to use hormone replacement therapy in those patients. So if you had them and they're gone, we think it's probably okay, but we don't have a lot of strong data to support that it's safe, but we think that it's safe from the best available evidence. But again, if you have no antiphospholipid antibodies, if you need to be on hormone replacement and your lupus is otherwise quiet, it does seem like it's pretty safe if you need to be on that. So what about some other treatments? What about vasomotor symptom treatment? So again, all this data is from the general population, and it's not even that great of data for that population, for everybody, let alone lupus patients. But the best available data, again, we've talked about the hormone replacement therapy. It's usually 85% of people in the women's health study had improvement in their vasomotor symptoms. There have been several studies, or 2 studies, that suggest that kind of an herbal medicine, ashwagandha, could be helpful for the vasomotor symptoms. Of course, anytime you're thinking about an herbal therapy, talk to your doctor, make sure there's no interactions with any of your other medications. Sometimes some of the SSRI or SNRI, so antidepressant type medications, can be helpful. There have been a few suggestions that medicines like clonidine, oxybutynin, gabapentin might be helpful, but there's a little bit less strong data for those. And then there are some newer medications that are more directly targeted for vasomotor symptoms. The neurokinin receptor antagonists, they may also help sleep disturbance. So these are medicines that we can use in those patients who have antiphospholipid antibody syndrome and can't go on hormone replacement therapy. But you have to have blood tests to monitor for any liver test problems with those medications. So if you've had a history of liver problems, those also might not be for you. Okay, finally, just to kind of mention cancer risk that might be more specific for women with lupus. Overall, in general, there's a decreased risk in most studies of endometrial, breast, and ovarian cancer, but an increased risk for cervical dysplasia and cancer of the vulva. And that's thought mainly to be because we know that women who have the HPV virus, which is known to cause that cervical dysplasia, lupus patients have a decreased ability to get rid of that HPV virus. And so that's one of the things that increases that risk for cervical dysplasia. So again, important to continue to get pap smears and get screened for these things. Important to get all of your cancer screening and work with your rheumatologist and your primary care doctors to make sure that's happening. There also could be a role for the HPV vaccine, which in general in the studies that have been done appears to be safe for lupus patients. Although usually if you're on a biologic medication, because it's a live vaccine, we usually recommend that you time that when you're off the medication for a while so that you can clear that. We don't usually like to give those when you're on actively being treated with a biologic medication. And that's about it. I will give a plug for a couple studies that we're trying to do. We're participating in a study that's sponsored by both the NIH and the Lupus Research Alliance that is trying to look more specifically at patients who are in remission. So a lot of times that's older patients, but sometimes younger patients who have been in remission off of all their medications except for hydroxychloroquine. And we know that sometimes patients, all of their main lupus symptoms might be gone, their kidney symptoms and skin and rashes and joints, et cetera. But sometimes you can still have some cognitive effects, and sometimes you can still have some fatigue and brain fog and things. So there's a study where we're looking at, it's just an observational study, doesn't involve any medications, but we're looking at immune functioning in patients who are in remission compared to patients who are flaring, and also looking at brain function. So with an MRI and a PET scan to look at how the brain might be functioning differently. And I hope that might give us some, more data and more answers in the future. And then one other study that we're doing, we know we always talk about how protective hydroxychloroquine is, but a lot of our eye doctors push against it if you've been on it for a really long time. And, if you've been quiet for years and years, sometimes, we don't know at that point, is it still actually helping as much as it did when you had active lupus or in earlier years. So if you're thinking about stopping your hydroxychloroquine, if you've been talking about that with your doctor, not because of eye toxicity, in which case you should just stop, but if you've been thinking about trying to stop it, we're doing a study, again, funded by the NIH, where we're looking to see if it's safe for patients to stop their hydroxychloroquine when everything else has been really quiet, and you've had lupus for years and you're over the age of 55. So if that might apply to you, I do have some, forms out at a table at the front that has information that you can scan in. You can get in contact with me and our other study coordinators. So with that, I'll take any other questions that you might have.
Thank you. If there's any questions in the room, I can certainly come around with the mic. And we have some questions online, so I'll collect some cards, but if anyone has something, I'll start right over here. Oh, I thought you raised your hand as due.
Yeah, hand raising is fine too.
I can start with one from online.
Okay.
It's a little bit of a story prior. I just went through an egg retrieval cycle and had to take Lovenox. Sorry for any pronunciation issues.
Oh, you're good.
Lovenox during. I found the hormone injections made me flare, especially during the Menopur trigger shot. I ended up having to take prednisone to manage the flare during this cycle. Retrieval ended up being successful despite the flare. I want to do another round soon. Should I take prednisone as a preventative to combat a potential flare?
Congratulations on the successful retrieval. Yeah, so currently for medications, we usually just kind of use the medications you need to use for your lupus. Obviously, you wouldn't want to do this if you're on, things like cyclophosphamide or more serious medications. But I would say, in general, especially if you're doing the injections to prevent blood clots, again, as I mentioned earlier, that can also decrease your bone density. So I personally would be hesitant to use prednisone if you didn't actually have a flare. Just prophylactically, I would probably rather treat a flare if it happens and avoid any extra prednisone use if you didn't need it. But again, all those discussions should be done with your rheumatologist who knows you better and knows how things have gone, and also with your OB doctor as well. Not necessarily a right or wrong answer there.
Okay, and we can ask another. Are there any recommended medications for osteoporosis for a woman on birth control pills who already has osteopenia?
Yeah, this is another one of those areas where we don't have a lot of really good data for premenopausal osteoporosis. So that's an area that I hope that we can get data. I mean, even better if we can get it in lupus patients specifically, but I think that's even, further down the road to actually have good data to base these recommendations on. So there have been, again, it all kind of depends on how quickly your bone density is decreasing and multiple different problems. There have been some concerns in the past with using some of the bisphosphonate medications that are usually first line in premenopausal women because those medicines hang around in your bones for long periods of time. And there's been some concern that, maybe if you get pregnant down the line, your baby could be exposed to those medicines. But that being said, sometimes we do use those medicines. And again, it depends on pregnancy planning and those sorts of things. Sometimes we use the medications that can help build bone in premenopausal osteoporosis even before we would use that in, postmenopausal osteoporosis. So again, lots of different caveats, lots of things to think about depending on, all of your specific circumstances. So lots of good conversations with your rheumatologist, I think would be really helpful there. Okay, I have this question I'll ask. What general recommendations do you have for patients in premenopause, menopause, not curling on HRT with a family history of cancers, such as breast, lung, brain, or uterus? Should HRT be avoided for these patients? Yes, generally. Of course, there will always be specific circumstances. I would try, if you have a strong family history of cancers, I would generally try to avoid HRT if possible. So I would try all those other things first. If you get to the point where you have severe symptoms and you've tried everything else, and that can be kind of a risk-benefit conversation depending on how close of a relative it was that had the cancer risk, et cetera. And of course, every patient make an individual decision. But in general, I would say I would avoid hormone replacement therapy if you have a family history of cancers. Should HRT be avoided if a patient has frequent migraines and is on methotrexate or Plaquenil? I think, again, this is going to be a little bit patient specific. I would make sure you don't have any antiphospholipid antibodies as well. I think if you've had a history of migraines that tend to be really tied to your menstrual cycles, maybe it would not be my first choice for you, just in case that was going to, reintroduce estrogen and flare. Sometimes migraines get a little better after menopause. So now some of that might be more hormone fluctuations, and in some patients, just a consistent level of hormones can be helpful. But again, I might choose other things first and, again, readdress the question if other things are not effective.
Okay.
Any other
All right.
questions?
Then I guess we will wrap it up if there's no other questions. Thank you so much.
Yes, thank you. A little souvenir.
All right. Thank you so much. It is my pleasure to introduce Dr. Bitmansour from Fate Therapeutics and also one of our sponsors for today's conference.
Thank you, Megan and Susan, for inviting us to come back and give you an update on our studies. The topic is advancing off-the-shelf therapies for CAR T cells for systemic lupus erythematosus and lupus nephritis. So I want to take a kind of little different route and really look at what are the causes of lupus, and that's what we're most interested in, because once you have a better understanding of what leads to lupus, you can try to figure out how to solve that problem. So, excellent. Wow, these slides look really nicer on large screens. So chances are, if you look at a lupus research article, a review article, or even a lupus story, the first sentence usually is this or some form of this. Lupus is a complex multi-organ autoimmune disease. And you all know better than anyone that this really is true. It's really complicated because there's so many factors involved that lead to lupus. We know that genetics is a strong component, environmental factors. But what I really want to focus on today is the immune system and what causes the dysregulation of the immune system that contributes to the pathology that we see in lupus, and not just in lupus, but other autoimmune diseases. As you can see here, I've written B cells and plasmablasts and plasma cells, which are different types of B cells based on their maturation process. So when you consider the immune system, and this is what I studied, this is what really got me fascinated into science, is how amazing the immune system is when it works properly. Usually the immune system is dormant. It lies, it's kind of sitting there waiting for any perturbations, any infections. Once it notices an infection, let's say a cut in your hand, a bacterial viral infection, it ramps up, it activates. takes care of that pathogen, clears it, and then goes back to kind of a homeostasis, dormant state. What causes autoimmune diseases is when the immune system recognizes something on our own cells as something foreign. So it activates our cells and tries to remove it, but it can't because it's a protein, it's something that's in our cells. So the immune system stays constantly active, and it's ramping up the B cells and other cells in the immune system, including T cells and so forth. So we're in this constant activation stage, and that leads to the organ damage and all the manifestations that lead to that are defined by in lupus. And as you know, one of the factors that your rheumatologist checks for to diagnose lupus is high levels of autoantibodies. The antibodies are proteins that are developed, produced, and secreted by B cells to target specifically on different types of proteins. Autoantibodies are, of course, directed at our own cells. So a person with lupus has a chance of higher levels of these autoantibodies, and usually that's one of the factors that leads to the diagnosis of lupus. So B cells are really important in lupus. They're not the only cause, but they are definitely a big factor in lupus disease pathology. Here I'm showing you a slide of the different types of B cells. They're generated from your stem cells in the bone marrow, as you notice here, and they go through multiple stages of growth and differentiation. And actually, they get the name B cells because they're first identified in the bone marrow. So they get the B from the bone marrow. So once B cells go through these differentiation stages, then they enter into the blood, into the circulation, and they traffic to different organs, different lymphoid organs, and as shown here, spleen and lymph nodes. And that's where they sit there waiting for any infections or any issues to get activated. So you can see B cells are distributed across multiple different organs. And that's one of the reasons why lupus is a multi-organ disease, because there's a big B cell factor. So where are we with therapies? On this column here, I've listed, to my knowledge at least, all of the current approved therapies for SLE and lupus nephritis. So we have a list of these general immunosuppressants such as hydroxychloroquine, steroids, immunosuppressants such as methotrexate and Cellcept. But on the bottom, we have targeted biologics. So those aren't the global immunosuppressing medicines, but they target specifically, for instance, B cells or T cells. As you can see here, there's only 4 that have been approved for lupus. And that's not for lack of trying. Many different molecules have gone through the research phase, the clinical phase, and they had just not been able to demonstrate efficacy and improvement in lupus, and therefore have not gotten approval. Now, in comparison, on the left column, you can see another autoimmune disease, rheumatoid arthritis. Aside from the conventional medicines, the conventional DMARDs, there's 13 approved targeted therapies, and that's compared to just 4 in lupus. So I think this really underscores the challenges in identifying and developing positive therapies for lupus. And as I said, it's not for lack of trying, it's just really hard. The good news is CAR T cells. I know you've all heard about CAR T cells by now. They were introduced in the world of lupus around 2020. But CAR T cells were actually first investigated in different types of cancers. And like lupus, some cancers are B cell driven. So we have a B cell that becomes malignant. So CAR T cells were developed to target those malignant B cells, and they showed really good promise. So around 2020, a group in Erlangen, Germany, made that kind of association. If we have a B cell driven disease that has shown really good responses with CAR T cells, why can't we apply CAR T cells to another B cell driven disease, in this case, lupus? And in fact, that's what they did. On the top study, they had the first reports in 2022 where they had studied 5 lupus patients that have been refractory to multiple prior therapies. So they were treated with multiple therapies and they were still either stopped responding or just did not respond from the start. They were enrolled in this trial where their cells were taken, the CAR T cells were manufactured and then reinfused back into the patient, and it was just one single dose. What they observed was remission in all 5 patients, even after 3 months. So they saw remarkable responses, and those responses were durable. The patients were able to reduce and discontinue their background therapy, and it went through multiple months of observation. So they followed that study with this article here, which was published in January of this year, where they expanded the lupus patients to 10, and they actually included other autoimmune diseases as well. They saw the same results. Really good responses, remission in 9 out of the 10 lupus patients that lasted through 6 months. They were on stable immunosuppression, and the patients were doing really well. Everybody got excited, including Fate. And we decided to explore lupus with our CAR T cells that we developed. So before I get into our studies, I just want to go a little bit more into detail about what a CAR T cell is. I talked to you about B cells. T cells are also another critical cell in the immune system. They have unique characteristics. As you see here, it says T cells eliminate their target cells by secreting lethal chemicals. So the T cell synapses with a target cell. Once it recognizes that, it secretes these chemicals that basically melts the cell. Some of you may have seen some really nice pictures and videos of that. So that's how a T cell destroys, let's say, a target malignant cell. B cells, as I mentioned, generates and secretes antibodies. Those are really specific molecules and proteins that target specific types of cells. So with CAR T cells, we're kind of merging that together, and that's why it's called chimeric antigen receptor. So you take a antibody that's targeted against the B cell, and you insert it into a T cell. So using that antibody, it's going to go find its target specifically, and then the T cell, once it makes contact with that target, kills the cell. One of the benefits of CAR T cells that we think that works better than, let's say, just the basic antibody-based therapy is that CAR T cells can penetrate into the deep tissues. If you recall, I showed you the different organs that the B cells generate and go into. A circulating antibody usually, for the most part, remains in the blood, whereas a T cell can actually traffic and enter those deep tissues. And that's where we believe a lot of the quote unquote pathogenic B cells lie in diseases like lupus. And that's why we believe, and others believe, that these early results with CAR T cell therapy have shown so much promise because they actually can go into the deep tissues and remove those pathogenic cells. So I told you about those, the studies done in Germany. So generating CAR T cells or autologous CAR T cells, meaning cells from the own patient, is rather complicated. It involves removing the blood, as I said, taking the cells back into the lab, engineering the CAR T cell, expanding those cells to sufficient numbers, and then reinfusing them back into the patient. As you can see, steps 3 to 5, can take a long time. And it's often very costly, and it's only can be only done in expert academic or centers. So it's not really widely accessible for now. What we have done at Fate is develop a platform for pre-making CAR T cells. We've pre-generated these CAR T cells from a healthy donor that are targeting B cells, and we freeze them and bank them, and they're ready, and that's why they're called off the shelf. So they're ready for immediate infusion. And this makes them accessible to many different centers, and it doesn't have to be to unique centers with experience in CAR T cell delivery, and it dramatically reduces the overall cost. So what we hope to do is make CAR T cell therapy and delivery more accessible and more cost effective, similar to the current therapies. So with that, we did our phase 1 study. We started about 2 years ago studying patients with SLE and also lupus nephritis. And I'm going to show you some of the results that we have. As you can see here, this is the baseline characteristics of 16 lupus patients that enrolled in our study. Based on the description, you can see these are very typical lupus patients. Young women, childbearing age. They had been living with lupus for many years, 7 on average. They had been through multiple prior therapies, but had not responded or stopped responding. A little over half came in with lupus nephritis. And on the bottom, you can see the systemic lupus erythematosus disease activity index, which is high, meaning they had moderate to severe disease. Their physician global assessment was high, and they had high fatigue scores. So they came in, they were really fatigued, as you all, I'm sure, can identify. They got a single dose of our CAR T cells following preconditioning. And first, I want to show you the safety results, because with the phase 1 study, the primary focus is safety. How safe is this aside from the efficacy? There's a couple of signals that one looks for when looking at cell therapy or CAR T cell therapies. It's called, one is cytokine release syndrome. It's a sudden activation of the immune system that is often associated with cell therapy. Another one is ICANS, which is a neurotoxicity, and in our case, graft versus host disease. As you can see here, we had 4 cases of low-grade CRS, none of high-grade CRS, and the low-grade CRS was resolved by antipyretics, and in one case, anti-IL-6 receptor. The patients recovered and continued to be in the study. Unfortunately, we didn't have any case of neurotoxicity of graft versus host disease. None of the patients had dose-limiting toxicities, meaning that when we tested higher and higher doses, it did not have any negative effects on them. And we have some infections and cytopenias reported, usually associated with the conditioning and not necessarily with a CAR T therapy. So overall, it was a pretty clean safety profile. And I have to say, across the industry, fortunately, that's what we're seeing with other CAR T cells. They're having similar results. So fortunately, it's a clean safety profile, which enables us to move on and study the efficacy of the cells. So I'm showing you here the results in those 16 patients in their lupus disease activity. They had improvements in their, for those patients that had kidney disease, they had improvements in their protein in urine. That decreased. Their disease activity in lupus measures decreased. Their physician analysis and examination of their disease, that also decreased. And their fatigue improved. So they were less fatigued over time. And here we're showing the over different patients at different time points for up to 21 months. I hope what you can see here is the overall trend is that they responded pretty early. Within 3 months, you see a significant drop in their disease activity measures, and they maintained those for the most part over the time. So it was a pretty rapid and durable response in the lupus disease measures. I started this presentation with B cells and migrating to tissues and CAR T cells, targeting B cells. So what happened to their B cells? We examined B cells both in the circulation, but also in the secondary lymphoid organs. And for both, you can see from baseline levels to after getting the T cells, we see a significant drop in the B cell numbers, both in the blood and in the lymphoid tissues, which is what we expected, but we certainly needed to demonstrate that. And I'm showing the lymphoid tissue because I want to make the point that as I was showing you earlier, the B cells migrate to different secondary lymphoid organs. So it's important to see what happens there following CAR T cell therapy. The interesting thing is the B cells return. They don't stay low. They start coming back around, starting at month 1, but really at month 2 and 3, they really ramp up and they come back to generate normal levels needed. Fortunately, the B cells that are returning are quote unquote naive B cells. They're healthy B cells. So those those subsets of B cells that are associated with pathogenesis remain low, but the returning B cells are primarily these naive and healthy B cells. And furthermore, patients did not lose their vaccine titers. So there was no need for them to be revaccinated because they maintained that vaccine memory from their prior vaccinations. So based on these studies, these positive studies, we designed our phase 2 trial. This one is very similar to our phase 1 trial, but this one is only focused for patients with kidney disease, with lupus nephritis. And it's open now, and the study steps are pretty similar to our phase 1 study, where patients that come in, they get pre-treatment with a conditioning chemotherapy, then they get a single dose of the CAR T cells. We don't require hospitalization with a lot of CAR T cell infusions. The participants are required to stay in the hospital for 7 to 10 days or so just to monitor. Ours, we don't require that. Usually it's just a few hours for checking for infusion reactions. Otherwise, they're free to go home. And then we just go to some monthly follow-up, 1 week for the first month, and then monthly for 3 months, and then switches to 3 months up to 2 years. So who qualifies for these studies? Obviously, patients that have SLE for phase 1 or lupus nephritis for phase 2 study. They should not have any neurologic disease or brain or neurologic disease. Usually patients come in, we require them to have gone through at least multiple prior therapies. So they must be refractory to at least 2 or more, not responded. And as you saw from the early studies, most of them were, all of them were. And furthermore, not pregnant or breastfeeding and willing to use birth control. So this is a very general kind of description of the patient that would be enrolled in our study. If you'd like any more detailed information, please visit our website to look at the detailed descriptions of this. Please speak with your rheumatologist and see if this is something that's that you can possibly explore. And I think my time is up, and thank you for your attention.
Okay, thank you so much. If you want to speak with anybody at Fate, AstraZeneca, they have booths here. There's also a booth here, a table for Dr. McMahon. She has a couple of studies she mentioned. We're going to break for lunch. The food is here for anybody that's live streaming. Please come back to have a discussion with Dr. Azzam on holistic care and lupus and Sjogren's, and then we'll have our patient advocacy panel. So in this room, you can take some lunch. There's a space outside that's a little bit warmer. We're going to warm up the room a little bit. And of course, you can eat at your tables. Thank you.
Okay, we're going to get ready for the afternoon portion of our conference. If we can find our way back to our seats, hope everyone enjoyed lunch. Had a little break, something fell. Here we go. Oh, okay. Just give everyone a moment to make it back to their seats. Hello again. Okay. Well, it is my pleasure to introduce the first speaker of the afternoon, which is Dr. Azzam. I'll let him tell him more about himself.
Hello. Thank you for having me. I want to thank the organizers of Lupus LA. And I'm a rheumatologist and I practice in Los Angeles. And my niche in rheumatology is musculoskeletal ultrasound. So I use ultrasound to help other rheumatologists diagnose things earlier. We use it for procedures to have more safer procedures as well. And I also sit and help the Sjogren's Foundation. We're working on the good practice statements to help other doctors in the community identify and diagnose Sjogren's disease earlier. And it's my understanding that there's a lot of interest in Sjogren's disease here. So I was asked to help present this. And I thought that maybe a good way to present this would be looking at holistic care of patients with lupus and Sjogren's disease. So our learning objectives, we have multiple, and it kind of nicely encompasses everything we learned today from the other speakers. And we're going to first look at Sjogren's disease, comparing it to lupus, maybe some of the differences, some of the similarities. We're going to look at the pharmacologic landscape of this. We're going to see what therapies we have available. We're going to look at the comorbidities. We're going to look at the ocular and oral health, specifically in Sjogren's disease patients, as that's where most of the morbidity lies. We're going to look at the burden of psychosocial aspects, anxiety, depression, fatigue. We're going to hopefully identify some tools to help these patients. And we're going to use evidence-based lifestyle modifications and see what kind of recommendations we have in our guidelines to help our patients. We'll also be looking at preconception counseling and lastly, identifying the multidisciplinary approach for our patients. Lupus, Sjogren's, and why holistic care matters. Well, first, let's look at lupus and Sjogren's disease. There's a lot of similarities of lupus and Sjogren's, one being that they're both autoimmune conditions that have a wide spectrum of variability. They could be mild, they could be very severe. And most of them, both of these conditions can attack the whole body systemically. What's different about Sjogren's and what's classic about it is that it is a disease of dry eyes and dry mouth. The immune system specifically targets what we call exocrine glands, the glands that are like, for example, the salivary and the lacrimal, what produces saliva, what produces tears in our eyes. And so it's classically known as a dry eye and dry mouth disease, but we know that there's more to it than that. It can attack the lungs, the kidneys, the skin, not too different from lupus, just different variabilities. And in terms of autoantibodies and how we identify Sjogren's disease versus lupus, there's some specific antibodies to lupus, which you may know about already, double-stranded DNA, it's anti-Smith antibodies. There's a specific antibody in Sjogren's disease called SSA, and this can also be seen in lupus. But this antibody may portend certain consequences in Sjogren's disease, which we will review. The other key comorbidities in lupus versus Sjogren's disease is that Sjogren's can have a 20 times increased risk of lymphoma compared to the healthy population. Lymphoma is basically a cancer of the lymphatic system, so your lymph nodes. And this is certainly something that we screen for in our Sjogren's disease patients. And some of the unique consequences of Sjogren's as well is dental caries, cavities, and corneal damage. Cornea is the lens around the eye that is basically the white part of the eye. And as we already learned earlier too, in lupus, some of the key comorbidities include cardiovascular disease, classically lupus nephritis, which is the kidney disease, osteoporosis, and infections. In both these conditions, we have a high prevalence of fatigue and depression. And we have already seen earlier with the other speakers that we have multiple therapies approved for lupus, although we have more in the pipeline, thankfully. But unfortunately for Sjogren's disease, we don't have any approved therapies, and hopefully that's going to change in the next year. So when we look at lupus and Sjogren's, they can be closely related. We've seen that there's about 1 in 4 patients with lupus will also have Sjogren's disease. And again, they're both systemic autoimmune disorders. They can be heterogeneous, which means they could present in different ways. They could have a wide spectrum of presentations. They could be mild versus severe. And they both have a predilection for females. Lupus in reproductive age females and Sjogren's in midlife women. And something I learned too, that why females, well, it seems that females have a stronger immune system. So it protects them in terms of fighting infections more easily than males. But there's probably the counter effect where it could be too strong and potentially dysregulate and cause these certain conditions. So with that, the holistic approach is important because there's a heavy burden of fatigue, pain, and reduction in quality of life. A lot of our medications and the trials, they look at disease score outcomes, of course, because we want to prevent damage, skin disease, organ disease, such as the kidney problems. But the secondary outcomes, which they don't primarily target, are the quality of life outcomes. Well, we'll start with also the foundations of pharmacologic management, as controlling the inflammation is extremely important. So the cornerstone, especially in lupus, is, as you probably know, hydroxychloroquine or Plaquenil. It is the cornerstone of lupus because it's been shown, one, to improve and delay organ damage, improve mortality, decrease flares. Some interesting things it can also do is decrease thrombotic events. So we think that it improves cardiovascular disease. And it can do this also by improving lipids, which is your cholesterol, and glucose and insulin levels. And maybe there's some photoprotective properties. Especially in our pregnant patients, we strongly recommend to continue Plaquenil because it can improve outcomes in these patients. We also recommend it in certain Sjogren's patients as well. The image you see here on the bottom is the retina. This is what our ophthalmologists look for to detect early whether Plaquenil is causing any problems to the eye. So this is why if you're on Plaquenil, your rheumatologist is sending you to your ophthalmologist, because we are all aware of the scary risk of retinal toxicity, which can change your vision. And historically, before all these measures, people did lose some of their vision. So we could see early when Plaquenil might deposit and stop the medicine when needed. So what we do for our patients in terms of screening, when we first start Plaquenil, we get a baseline examination in the first few months. And then as long as there's no comorbidities or risk factors like kidney disease, or some patients may be on a medication called tamoxifen, which can increase your risk of ocular problems, we take a break for about 4 to 5 years. And then after 5 years of therapy, we screen patients annually, once a year. And if we follow this protocol, the risk of retinal toxicity is less than 2% at 10 years. Another treat to target recommendation is glucocorticoid minimization. So basically, part of our remission criteria, especially in certain studies, we look at disease score, and part of that we always want to look at their prednisone dosing. So it's really big for us in rheumatology because although prednisone can cut inflammation very quickly and relatively easily, obviously we know a lot about side effects from it. We learned a lot of this in the 1950s when we didn't have a lot of these therapies, and people got a lot of glucocorticoids and developed many side effects: high blood pressure, diabetes, avascular necrosis of the bones, osteoporosis. So these are all things that we watch out for, and your rheumatologist is trying to carefully monitor to bring your glucocorticoid dosing down. When able, we try to withdraw the glucocorticoids entirely. And we use other immune modulating or immune suppressive medications to help us do that. That includes methotrexate, leflunomide, azathioprine, and then some of the other biologics you've heard of earlier in the talk, such as belimumab, Safnello. And What we know too, so that I want you guys to take away from this is that if you're feeling well, but you're on prednisone, 10 milligrams or anywhere above 5, I would say that you're not quite in remission at that point because the whole goal is to try to get your prednisone down too. So that's something to keep in mind. So of course, in Sjogren's disease, we have a treatment gap because we don't have anything approved. We've tried Plaquenil for this. We only use it in specific circumstances, maybe skin disease, maybe joint pain, but for the fatigue, for the dryness, it has not been shown to help. But there's off-label biologics we adopt from lupus studies and we use once we've maybe identified organ damage in Sjogren's disease. So there isn't really immune modulating or immune suppressive therapy we give up front to prevent progression in, for example, a mild Sjogren's disease patient. So therefore, symptomatic and preventative therapies are the primary treatment for Sjogren's disease at this time. The cornerstone for Sjogren's is SICA symptom relief. SICA is the Latin term we use for systemic dryness. We work on pain management, surveillance for lymphoma, as we discussed, comorbidity prevention, such as cardiovascular disease and corneal damage, and psychosocial support. So for Sjogren's, especially, let's focus on ocular and oral health. There's a stepwise approach to SICA syndromes. And the number one thing I would say is there's a lot of medications that can cause dryness, whether it's antihistamines, antidepressants, and certain diuretics as well. You want to identify these medications, see if you could come off of them before chasing your tail with certain therapies. And the next biggest thing is identifying your environment. So a lot of patients with SICA syndrome, they respond well to a more humid environment. And if you see the glasses up here, these glasses help adopt a humid environment specifically for your eyes because it encloses the sides of the eyes, preventing dryness from the wind or vents or smoke or anything like that. So the other thing for oral dryness, there's sugar-free gum that we ask patients to use. We use sugar-free because you're already at risk of cavities and we want to reduce the sugar load that you have. And frequent sips of water, and again, the humidified environment, especially when sleeping, is important. One interesting thing that some people have tried to use is called oil pulling. And oil pulling is when you try using coconut oil to swish in and out of your teeth. It doesn't taste very good and it's not very effective, but it's something that some providers have tried. Another step is to use topical therapy. So topical therapies would be things like artificial tears, ocular gels. These are gels you put in your eyes when you sleep at night so that it stays lubricated when your eyes are closed. What I would say is to make sure you identify and obtain preservative-free products because the preservatives in someone who already has corneal damage can further cause dryness in the eyes and more issues and allergies even. If these fail, then the next step we go to is what we call secretagogues. They help secrete moisture, saliva, and tears. And there's a couple main medications that we use, but one thing to say about these medicines is that they may not work if the disease has damaged the salivary glands to a certain extent. So what they do is they help release the saliva, but if the gland cannot produce it, then it may not work. And so we do rely on our oral health specialists to tell us after maybe something like a stimulated salivary flow exam, whether these therapies might be beneficial for you. And when to escalate for dry eye treatment, we rely on our ophthalmologist for this. So you start with the artificial tears, we go with the nighttime gels, and then we do have anti-inflammatory therapies that are topical eye drops that you put on the eyes. And this helps reduce the inflammatory disease in the eye. Sometimes the ophthalmologist will also decide to do what's called punctal plugs. And these are plugs that you put in the ducts of the eye to help reduce drainage. So you think of this as if you're going to take a bath. So you plug the bath so that you can allow the water to fill up and take your bath. This is very similar. You put plugs in the tear ducts of the eye to allow for the eye to retain the moisture. So our ophthalmologists serve twofold. They help detect the type of dry eye. They help detect corneal damage and what type of therapy might help this particular patient. And they also actually do this Plaquenil screening, of course. And so we rely on them for multiple things. And to the oral health topic again, I think someone asked this earlier, why patients might be more prone to cavities. Well, your saliva acts as a buffer to the acid in the mouth, and that buffer helps control bacteria and helps remineralize your enamel. So when you lose the saliva, you lose that pathway and you could develop rapid dental caries or cavities in the mouth. So other than the therapies we already discussed, your dentist might prescribe you a prescription grade fluoride to help protect the enamel. We definitely are recommending, and the guidelines that will come out, we're endorsing that people see the dentist every 3 to 4 months at least, so that they could get routine cleanings and examinations. Of course, we discussed the sugar-free products. We do want to avoid sugary drinks and acidic drinks as well. And the other thing to watch out for is oral candidiasis, or we call thrush sometimes. And this could occur with a higher predilection in Sjogren's patients, but also can mimic dry mouth. So sometimes we treat people with oral thrush, and they might present in different ways without just the white plaque, and sometimes their dry mouth gets better. So remember, your oral health specialist, usually your dentist, is part of the care team, and you want to ask yourself when you last went. Make sure you inform your dentist that you have a diagnosis of Sjogren's disease or dry mouth and strategies to reduce that. So the cardiovascular risk and other comorbidity screening, we heard a little bit about this as well, but it's true that lupus can increase your risk of cardiovascular disease. We see it in our younger lupus population compared to what we call age-matched controls. And it's a risk-enhancing factor. So there's a lot of rheumatologists studying heart disease and lupus. And so what we do is we're more aggressive up front with certain risk factors that we can control. So if there's a blood pressure target, we try to meet that. If the cholesterol is too high, we try to intervene with that. If they have certain risk factors that add to this, we might recommend a low-dose aspirin. And we use something called the ASCVD, which stands for atherosclerotic cardiovascular disease. It's a risk calculator that us, the primary doctors, and the cardiologists use to help determine a person's risk. And of course, to improve cardiovascular disease risk, we always want to minimize glucocorticoids. And as we kind of touched on, Plaquenil can also improve cardiovascular outcomes. So this is a checklist. This is not exhaustive, but a lot of what your rheumatologist in the background, the back of their minds during their visit with you are always thinking about. And we share this with the primary doctors and other specialists who are along with your case. And of course, there's the cardiovascular disease and the screening that we provide for that. There is the kidney disease that your rheumatologist monitors. There is osteoporosis. We measure that with bone density, especially increased risk at those who are on chronic steroids. Similarly, diabetes and metabolic syndrome. Really importantly is malignancy, so cancer screening. We really want to make sure, especially people who are on immune suppressants, that we're doing our age-appropriate cancer screenings. Retinal toxicity we reviewed, and then infections. So before starting immune suppressives, we screen for infections, and vaccinations have really helped reduce hospitalizations in a lot of our patients. And you want to review with your rheumatologist which ones are appropriate for you and at what time. Ideally, we do some of these vaccinations before we start immune suppressives so that they can have the most efficacy. So getting back to mental health, fatigue, and quality of life. So there's a large burden of this in our lupus and Sjogren's disease patients, as you can see. And much of this is independent of disease activity, meaning your lupus nephritis might be in better control, but you still might have a lot of fatigue and discomfort or depression in certain areas. And so we really want to use a holistic approach when we address these quality of life circumstances. So what are some screening tools specifically for depression? What we do in the research setting, what we study is PHQ-9 and GAD-7 for anxiety. These are scores that we use, like something you may have heard of called the SLEDAI for disease activity for lupus. We do this in studies. We don't always do this in the clinical practice setting, but we certainly should be screening for depression. And when we detect this, or when the patient brings it up that, this may be an issue, then we certainly refer to psychosocial services for support. And you could get this also by like local communities. For example, the Lupus LA Foundation has support and social workers. So there should be opportunities in your community to help identify this. For Sjogren's, there isn't a proven medications to help with fatigue. So maybe Plaquenil might help for lupus, but for Sjogren's, it hasn't really been shown to do that. So other therapies that have good evidence is cognitive behavioral therapy, mindfulness-based stress reduction, and we mentioned some of the psychoeducational interventions. And then probably one of my favorites is exercise. We're going to speak about exercise a little bit more. So what I want everyone to know is that exercise is safe and well tolerated and does not increase disease activity. And that includes some of our autoimmune conditions that specifically attack the muscle. We're almost all the time recommending some form of exercise. Either it's aerobic, resistance training, and what we've seen in studies is that across the board, it helps with disability, pain, fatigue, and depression. So there's a lot of mood benefits that overlap with using exercise as a modality. And from studies, we've seen that less than 30% of patients are meeting the minimally recommended guidelines to perform exercise. So there's a big gap that we can address here. So if you're deconditioned, you haven't spent a lot of time exercising, you want to avoid injury, you want to go slow and start low. A lot of times we recommend starting with low impact exercises. Some of the best evidence that we have might be something called Tai Chi and Pilates. So starting from there, and maybe even it's just doing an activity you enjoy, whether that's walking, and then from there you kind of increase the load. Eventually, you want to get to the point where you're performing at least 150 minutes of exercise a week. And then eventually want to add resistance training, because we know that resistance training is good for longevity. It's good to have the muscles in the future, especially to prevent falls, and balance training. And in the European guidelines, this is actually a strong recommendation and something not to be taken lightly. Of course, for lupus patients who have photosensitivity, if you're going to do some sort of outdoor activity, you want to protect yourself or avoid when the UV index is highest. Another question a lot of us get is what sort of diet fits with me and what would help my lupus or Sjogren's disease the most. I'll start with saying that there's usually no one diet that fits everybody. So everyone's kind of on their own journey with this, but what has maybe the strongest recommendations and what's recommended in our American College of Rheumatology guidelines is a Mediterranean diet. And I have a table here to tell you what that is. So that is basically vegetables, fruits, and whole grains, and basically making high fiber the base of the diet. What we're learning is that high fiber is really good for the microbiome that you heard Dr. Wallace discussing. Then it's fatty fish, high in omega-3s, maybe 2 servings per week. And then a little bit less than that would be poultry, eggs, and dairy. And then things to minimize would be red meat and sugary foods, especially ultra-processed foods and processed foods. So if we can kind of avoid the processed foods, that'll probably make the biggest difference. And so our 2022 ACR guidelines seem to support this theory. And that came from this paper that was published in 2018. It looked at over 7,000 people, and it compared these people eating a low-fat diet compared to a Mediterranean diet that allowed for a liberal amount of extra virgin olive oil. So it was kind of a moderately high-fat diet, but with olive oil. So, and the reason why they wanted to do that is because they thought maybe polyphenols and omega-3s were good for the body and anti-inflammatory. And so they showed that there was a relative risk reduction in cardiovascular disease in these patients, in the patients that were on the Mediterranean and liberal extra virgin olive oil diet. And this was published in New England Journal of Medicine. And then also there were additional smaller studies that looked at specifically lupus and Sjogren's. And there was some small improvements in inflammatory disease activities as well. Another question might be about nutritional supplementation. Vitamin D is probably the biggest one. I'll focus on this one because obviously lupus patients are usually sun avoidant, and so they might be more prone to vitamin D deficiency. We've seen that vitamin D might have some roles in B cell regulation and T cell and dendritic cells. But interestingly, there was a study last year by Hopkins in 2025 where they looked at the opposite ends of extreme of vitamin D levels, so whether it's very low or very high. And they found that there is an increase in miscarriage and preterm delivery in patients who have the lowest or the highest forms of vitamin D. So from this, they made a recommendation of a vitamin D range of between 40 and 59. Has not made it to the guidelines yet. We'll see if it does, but just something interesting that came out last year. And of course, if you can't get your vitamin D through sunlight, probably the easiest way is supplementation or foods, so eggs, salmon, wild-caught salmon, and fortified milk. So I lumped photoprotection and smoking cessation together because the commonality between these two is that smoking and UV radiation both can damage your DNA. And that's how it can cause flaring a lot of times in your autoimmune disease. Your immune cells recognize the damaged DNA and they become inflamed. So photoprotection is actually a disease-modifying intervention. It can reduce your disease activity scores. And I put a study here that looked at how significant certain sunscreens work. And it showed that there was a 0% flare in skin disease when sunscreen was applied to a certain skin patch, whereas there was a 60 to 56% flare in the control group. Similarly, with smoking cessation, smoking actually makes it more difficult for your medications to take effect. So we definitely refer to cessation services early on. Sleep is, of course, very important. If we don't have good sleep, then we have increased pain, fatigue, stress, and pain, fatigue, stress worsens your sleep as well. So it's a vicious cycle that can cause a downward spiral. And then some of these patients will go on to develop depression, fibromyalgia, and then you have a really tough time trying to manage everything. So there's certain causes of sleep problems besides just insomnia, because you just wake up with racing thoughts. Some people could have sleep apnea. And so if you have morning headaches or you snore at night or you wake up choking, you want to let your doctor know because then you should get a sleep study. Some people might have restless leg syndrome. Some people might wake up in the middle of the night too frequently because they have to urinate or because they have a dry mouth and they need more humidification potentially. And then glucocorticoids could also cause insomnia too. So you want to work on the timing of that with your doctor. And depending on the cause, some things that could be offered, again, is cognitive behavioral therapy for insomnia is what the CBTI stands for. And this is basically the first line therapy for any sleep disturbance. Standard sleep hygiene, I'm sure you've all heard, consistent schedules, dark rooms, and turning off your iPhones in the middle of the night, a humidified bedroom, which we discussed, and then if you have sleep apnea, you want to address that. So reproductive health and pregnancy planning, you want to approach your rheumatologist 3 to 6 months in advance. You don't want to surprise your rheumatologist that you're pregnant. You want to plan early so that you want to discuss the risks. If you have heavy disease burden, you want to make sure it's a safe time to get pregnant. In addition, you want to make sure that you're off the medications that could cause birth defects. We call these teratogens, medications that could cause birth defects. The other thing your rheumatologist will want to do is check your antibody levels. So if you have antiphospholipid antibodies, you have additional risk factors you should consider. You should probably be on aspirin. If you have an SSA antibody, you need to be on Plaquenil because that reduces the risk of conduction defects of your fetus's heart. So what SSA can do, in some cases, it can cause electrical abnormalities in the fetus's heart. And of course, Plaquenil, we know, can also decrease risk of preeclampsia and preterm birth. So just remember, this is a team sport, right? So with the patient, with the rheumatologist, and the maternal fetal medicine team. And that leads us to systems of care. So a multidisciplinary team, meaning multiple team members of different specialties, really collaborate with the patients, with the rheumatologist to give you the best outcome and care. So it might feel overwhelming to have your rheumatologist maybe refer you to different doctors, but really, in this case, more brains are better than one. And so you might have the kidney doctor, the dermatologist, the ophthalmologist, the dentist, the psychiatrist, the obstetrician, and of course, your primary care doctor. So I wouldn't say that all of these things fall on your rheumatologist, but certainly it's in the back of their minds, and you want to work as a team together to address these things to give you the best outcome. Some take-home points then is, and no particular order, by the way, so photosensitive patients and lupus patients certainly want to protect yourself from the sun with SPF and proper clothing. Plaquenil is a cornerstone treatment for lupus. It helps improve disease activity and reduces comorbidities and cardiovascular disease risk. If you're a Sjogren's disease patient, you don't want to ignore your dry eyes or dry mouth because this can lead to morbidity down the line. You want to focus on your mental and physical health because this really gives you the umbrella for your quality of life. These are things that you want to approach with your rheumatologist and your primary care doctor. Of course, you want to build your team as we discussed. And then the last thing is to keep up with healthy habits. So work on exercise, work on some sort of movement, some sort of hobby that just keeps you busy or makes you happy, and dieting and lifestyle factors in that way. So that's all I have for you, and happy to take any questions.
Okay, thank you so much. Do we have any?
I'm going to start with a question that
Oh,
I'm so sorry. I'm going to start with a question that we got online, Dr. Azzam. It's long.
Okay.
I have been diagnosed with lupus for 3 years and have been on Plaquenil and LDN daily for those years, but my symptoms are still not controlled. What would you suggest? I still get the mylar rash from the sun. I have extreme fatigue, muscle and joint pain, dry eyes and mouth, and migraines. Additionally, I have POTS symptoms and depression. However, my labs almost always do not show active disease, so my doctor has not prescribed additional meds and says my lupus is controlled and that it's my fibromyalgia causing these symptoms. If my labs don't show active disease, does that mean I'm in remission and that these are not lupus symptoms?
Yeah. First of all, sorry you're going through that. It's challenging, and we do see this. I would say that probably what your rheumatologist means is that from an organ disease perspective, you're at low risk of developing organ damage, and that's great. But part of this talk, of course, is the quality of life aspect. So I would say that this is a sort of thing that does require a team approach, whether that is getting a physical therapist, a health coach to work on the physical activity aspect. The other thing is to look at your diet. You know, someone asked earlier about gluten in the diet and what that does. Well, we see a lot of people maybe who just have intolerance to gluten in their gut health, and sometimes that helps people with their energy. It's really a lot about history taking. I would start a food journal and start a journal of your symptoms overall and document what days you feel terrible and maybe what associations with that. The LDN, I would have probably done the same thing. I'm sure there's other options to offer, maybe approaching with a psychosocial support as well. But I think it depends on other factors that are more personal that might need an examination to understand whether maybe you would qualify for immune modulating therapy like belimumab or something like that.
okay, we have one question over here.
Hi, I have a question, and because I've seen mixed answers online about this supplement that's supposed to help block out sun if you're on Plaquenil. That's supposed to, I don't know if you know what I'm talking about.
What does it say on there? I'm sorry.
Heliocare.
Heliocare.
Yeah, it's supposed to block out additional sun.
Okay. What's the active ingredient? Just curious. I haven't heard of it.
Like it is. Oh gosh, I don't have my glasses on. It's.
So when it comes to
It's under the name fern block, but it's a plant.
Okay.
Plant.
Okay.
It says that you should, if you have lupus, you should take it.
Understood. Yeah. I'm sorry, I'm not familiar with that one. I'll say that with supplements, you know, it may work, but I think the biggest thing to know is that there's probably not the strongest studies done for this. A lot of people, you know, they'll ask me about supplements, and as long as it's not something that I think is obviously harmful, some might decide to try it and see if it works for them. I'm not familiar with the product. I'm sorry. I don't know if there's good studies done on it, but does it work for you?
I've only been taking it in a month, and I was said in your chat.
Yeah, excellent. I think regardless, you want to do sun protection, but I'm just not familiar with that supplement.
One online, and then I'm going to go back and forth in the room.
If it's okay, I actually have two about Plaquenil, so maybe we could just do those two quickly. If you're allergic to Plaquenil, and what else is available, especially if you have organ involvement like kidneys, heart, and brain, and we can acknowledge that it might be something specific to their disease state, but what would you like?
Absolutely. If you have organ involvement to that extent, I would say Plaquenil is not going to be the entire answer anyhow. At that point, you'll need to be on some other immunomodulating therapy. If it's more of a mild disease patient, or to the first part of the question, what else could you do that's similar to Plaquenil? There's other anti-malarials that were used, such as quinacrine. Sometimes it's hard to find these in certain pharmacies. You might have to call around or get it online. I think some people have gotten it from Canada before, but those are certain things you could try.
And follow-up, unrelated. My daughter had to stop Plaquenil after 11 years due to retinal thinning. Is that something that ever gets better so that she might be able to resume Plaquenil in a few years?
I would say no. I think once you've seen it start to affect the the retina, you simply want to avoid it for the future.
Okay, we're going to go one.
Quick question about smoking. Not here to be excited about smoking, especially nicotine, but I am curious about, say, other things that can be combusted into the lungs that might actually have, nice properties. A CBD, a THC.
Sure.
Is it the act of combustion that is the issue, or is it everything else that's in cigarettes?
I don't think it's the nicotine, it's the combustion. And you see this with other forms. For example, we actually published something called vaping-associated lung injury, where with certain vapes, whether it's THC or a nicotine product, they end up with, you're introducing like a toxic substance to the lungs. So that's the whole point of smoking, is that you're introducing in your tiny sacs of air and fluid in your lungs, and what it's supposed to do is exchange gases through. So then you're filling those airs with smoke and toxic substances, and then all of a sudden your immune system gets very attracted to that area because it's a foreign substance. So that's how it gets triggered. Good question.
Someone online asks, how common are flares or bright foci or lesions in the brain seen on MRIs caused by lupus specifically?
I think Dr. Wallace touched on this. The CNS lupus is thankfully a much more rare event, but it can happen. So that's certainly something to work up, and also depending on the age and comorbidities, sometimes these lesions can represent something else like a vasculopathy, like more of a cardiovascular disease risk.
I'll try to be concise because I get nervous. I am wondering if you can speak about the clinical considerations and possibly recommendations if you have a person who wants to get pregnant who has organ involvement in their illness. And I've been reading about this, and the recommendations are pretty confusing to come off the medications and also to be stable at the same time. Then sometimes they'll say take Rituxan beforehand, but then Rituxan, you're supposed to be off of it for a while, depending on who you ask. So do you have any thoughts on this particular situation for people who want to build the family?
Yeah, great question. So I think first and foremost is making sure the disease is stable, making sure the organ is stable. So it's always a risk-benefit discussion too, and it depends on which organ is involved. It's a really bad lupus nephritis. I would think most rheumatologists would recommend to not get pregnant until maybe a year or so out, or maybe 2, to make sure the disease is stable. So that's the number one thing. I would say to avoid pregnancy in certain severe organ manifestations. And then eventually when the condition is controlled, then you could reapproach that and see maybe what kind of risks are there. But yeah, certain medications, we don't know what they do to the fetus. Obviously we don't purposely study it because it's risky. But we have some case reports of, whether patients got pregnant and accidentally and took rituximab and their outcomes, and maybe they were okay. My colleague had a patient on Benlysta when she had her baby and they did okay. So a lot of it's anecdotal and small studies, but for the most part, we try to address that early. Once the disease is controlled, manage the medications to the ones we know that are safe, and then work on the conception.
Another question online, just for some background, this individual is taking Plaquenil, Benlysta, and prednisone for flares. They wanted your opinion on the addition of Eastern or alternative medicine into their holistic care. They found personally that acupuncture has eased some pain and inflammation, and just wanted your thoughts as well.
Awesome. Yeah, there's actually pretty good data behind acupuncture. So it's catching up to Eastern medicine, the thousands of years they've been doing it. So that's really good. But we do have, I believe there's a role for holistic care or in terms of integrative medicine and these things, as long as you're kind of reviewing what's being done with your rheumatologist and then kind of determining the potential risks of them. I think that should be fine.
Okay, we'll start here. I'll get to it.
Yes. My question is, so I take blood thinners. And so I have a problem with the vitamin K. So I would like to know, can you suggest any high fibrous type of vegetables besides carrots and cauliflower?
Well, if you're looking for high fiber, there's actually some great supplements out there. I mean, I'm sure if you're on the medication I'm thinking you're on, then you probably work with a dietitian already. If not, we should get you to a dietitian because they'll certainly help manage the vitamin K and the INR and these things. That's first and foremost. You need personal guidance from a dietitian. But if you're looking to work on your fiber specifically, there's also a lot of different supplements like psyllium husk or acacia fiber, these things. Sometimes these are supplements that help increase the fiber when maybe you don't have access to the foods or able to take some of these foods.
Another one online. Cellcept and prednisone cause increased cholesterol levels. When there's mixed results, cardiologists are quick to prescribe medication to lower cholesterol. But what's the point when you're still taking Cellcept and prednisone to control the disease? Do you have any recommendations for solutions or options, potentially any that are naturopathic?
I would approach it from a lifestyle perspective. If there's a metabolic syndrome like diabetes on top of this or obesity, then we certainly want to address it with from that background. Supplement perspective, I don't have any recommendations for that. From a medication perspective, I think the thing to discuss then is your cardiologist and rheumatologist can discuss how long you'll be on the prednisone for. And potentially the Cellcept as well. Obviously, the Cellcept will likely be more long-term, but that could be the way to go about it, is to decide like how long you're going to be on the prednisone for, if it's going to be a year or so. The other thing to note is that with these cholesterol-lowering medicines, they're chronic therapies and they're used to reduce the long-term burden we're learning now about plaque development in the heart. So it's really a long-term thing, and maybe the cholesterol-lowering medicine is temporary too, along with it. Similar to how we think when we put patients on vitamin D and calcium or antacids when they're on steroids for protection. That could be that you could look at it that way as well. And once you do get off the prednisone or Cellcept, then you could retest your cholesterol with your cardiologist and see where it goes from there.
I'd just like to know if we are able to get your slides.
Susan?
We will send the slides after the conference.
Yeah.
Hi. Over the last 10 years, I've had several episodes of what I think might be neurological symptoms like prolonged eye crossing and severe disorientation, confusion episodes. Is that always considered like some sort of brain inflammation? And is that just something that would indicate like a more some issue with, your disease activity?
I would not say that's always considered brain inflammation because it could be peripheral nerve as well. So Sjogren's, lupus, they can both cause peripheral neuropathy. I think Dr. Wallace briefly touched on that. But I would say that a neurologist, of course, and sometimes a neuromuscular neurologist can help determine that. And maybe even a neuro-ophthalmologist. So just like my specialty in rheumatology is ultrasound, ophthalmologists are subspecialized. There's some neuro-ophthalmologists out there that specialize in eye and brain connection.
Hi, doctor. Quick question. Any holistic approaches for like lupus fog or like when you forget things?
Yeah, so I think the biggest one is sleep. And it's not just working on your sleep at night, but we actually do also recommend that people try and fit in nap times throughout the day. It's obviously not always ideal with people's work schedules if they work, but it's certainly something that's been shown to help. Sleep, checking in on your diet as well to take note in a food diary to see if there's something that's exacerbating some of the fog. And then also exercise. So starting to do, I think Tai Chi as a low impact exercise that actually has good data for pain reduction and some energy levels.
Okay, we're right over here.
Hi, doctor. What do you recommend for somebody who has sexual dysfunction in lupus?
Sorry, say that again.
I'm sorry, I get nervous.
Oh, it's okay.
What do you recommend for people that have sexual dysfunction in lupus?
Absolutely. Okay, so part of the things with lupus and Sjogren's too is not only can you get ocular, your eyes, and oral dryness, you could get genital dryness too, like vaginal dryness. So that's something to discuss with your doctor. In that case, they have specific recommendations to help you. In addition, your rheumatologist can work with your gynecologist to kind of determine what that might be. So if there's multiple reasons why that could be the case, and certainly depression, poor sleep is just one, like two of many, many reasons.
And we have one more online. Earlier in the slides, I believe I saw a higher incident of lymphoma in Sjogren's versus lupus. Correct. Is there a clinical reason for this?
We think from the pathophysiology of Sjogren's disease, which is predominantly B cell, whereas lupus may have almost all other lineages, but the strong B cell, which has a high prevalence in lymph nodes. And so lymphoma is essentially a cancer of the lymph nodes. And so we think that's why, because of where the inflammation lives.
Since that was brought up, I'm going to ask this. I got diagnosed with MGUS and with kappas and gammas. Correct, and all of this, you know what I'm talking about. Yeah. And I was told this is because of my lupus, and I was wondering if you could comment on this and if there's anything. I'm told, well, your lupus should be put under control. Can you respond to that?
Yeah, so kappas and lambdas, and these are two what we call light chain proteins that are attached to your immunoglobulins. Your immunoglobulins being antibodies that your B cells secrete. So what happens in inflammation, especially as it pertains to B cells, is they produce a lot of antibodies. And so then at that point, you can get something called a polyclonal hypergammaglobulinemia, where you have multiple gamma globulins or antibodies. What's important about the light chain is the ratio. So if the ratio is roughly equal, that tells us that it's most likely from an inflammatory standpoint and not necessarily a cancer standpoint. When we start seeing something called a monoclonal, meaning one type of cell that's overproducing proteins, you might get a kappa lambda ratio that is much higher than the other. They're not very equal. So those are the settings I would say maybe should be monitored more closely, but also If there is true MGA, so that means that insinuates there's a monoclonality, then a hematologist should be following you as well.
Still?
Just following up on the idea that lymphoma would be triggered by the B cell predominant disease. With this new drug Uplizna or inebilizumab,
Yes.
that is able to treat the B cells both in circulating as well as in the lymph and the bone marrow. Could that possibly
Great
be?
question. Yeah. So actually, the oncologists use that as one of their therapies, not specifically those drugs, but rituximab, which is a B cell depleter as well. They use that as part of their protocol to treat the lymphomas too. So maybe, you know, if these are used earlier, they might prevent the risk of lymphoma, but that's a possibility.
I think that was everybody's hand.
Thank you so much, Dr. Azzam. I also want to just let everybody know that Dr. Azzam, as the other doctors that spoke, you know, practice here. And so if anybody wants to be in touch with him, he's a part of Attune Health. Please just email us at info@lupusla.org and we can give you the information for the doctors.
Thank you all. Appreciate it.
Thank you so much.
Okay. I think now we're going to welcome up our patient advisory panel.
Yeah. So we're going to have our patient advocacy panel. I think right now we have 2 people, Sharan and Lorena, in the room. I think that Cambria was also joining us, but I'm not sure she's here yet. So ladies, if you want to join us, we're going to do this sort of as a roundtable discussion. No specific topic. We'll have these amazing women introduce themselves and then we'll open a discussion. So about 2 years ago, we created this patient advocacy panel because so many patients in the community, you know, really wanted to get involved. And what we felt was that, you know, these conferences are great doctor to patient opportunities, but a lot of community here is interested in patient to patient discussions. And so we have 6 incredible women. Here are 2 of them. I'll have Sharan and Lorena introduce themselves, even though you have their bios in your folders, and then we'll have a conversation. So Lorena, do you want to start?
Sure. Good afternoon, everyone. Thank you for coming out and being here with us today. My name is Lorena Gordon. I was born and raised in New York. I was diagnosed with lupus at the age of 13. And yeah, I am a filmmaker, so I strive to give representation for illnesses that are, you know, invisible, and create them in cinema so we can spread awareness and be represented.
Hi, everyone. My name is Sharan. I am from Irvine, California, and I was diagnosed with lupus when I was 15. And I'm currently a nursing student at UC Irvine. And so my goal is to hopefully work into rheumatology and also combine holistic medicine and Western medicine in my practice.
Hey, thank you so much. So really the opportunity here is to sort of talk about anything that anybody wants to discuss, and whether it's employment or being a student or a partner or a patient, please, raise your hand, and it's always the hardest, the first question, and then we seem to get things rolling as people join in. Here we go. First.
As a nursing student, did you request any special considerations from your school? Because I'm a nursing student right now.
Yes, I did request accommodations. I've actually been in a previous healthcare training program. I was in a physician assistant program before nursing school, and unfortunately, they were not able to accommodate me. So I had to fight with the disabilities office and really advocate for myself. But I decided to switch careers because nursing aligned more with what I wanted. My program has been very communicative with me and has really helped me so far. But I officially start in September, so we'll see how much I am able to be accommodated. Yeah.
Lorena, I don't think I'm on. Lorena? Sorry. We have a question online for you. As a fellow filmmaker, how do you manage overnight shoots? I go into flare if I stay up past 1 a.m.
I would say it it's about finding your balance and really being disciplined with your sleep and finding ways, like doctor had said previously, like taking naps. I'm a big napper. So finding ways to catch up on your rest, because if not, then yeah, then you will flare and you won't be able to make it at all. But yeah, it's tough because it's like mentally and physically exhausting.
Yes, so I've returned to school recently as well. And so my biggest challenge has been the stress. So I would like to know, do you have any suggestions? I also have the accommodations, but still, the stress really gets me. And so if you can talk about that, it'd be great. Thank you.
Yeah, stress is I like to call it a silent killer. It causes a lot of inflammation and sometimes it feels impossible to manage. For me, that's where I kind of turn to the holistic side. So that's where I incorporate like daily meditations. You could do them on YouTube. That really helps me. Also working with your program is very important. Whichever school or program you're in, ensuring if they can help you with like tuning into lectures online or being able to take more absences when you're feeling very stressed. I think something that really helps me is being able to do a lot of breathing exercises like breath work. Our breath really does change the way that our whole nervous system is activated. And so that's something that really helps me when I'm extremely stressed.
Hi. So 20th year with lupus here. I feel like I should be old hat, but there's always new challenges. And I feel like recently I have had the most clashes in my personal relationships, be they friendship or romantic, whatever the case may be, of, my lifestyle changes being inconvenient for others. Obviously, these are not things that we can always compromise on. And I'm curious if you've got any things that have seemed to have worked in terms of, obviously, I feel like quite well educated and I can explain these things, but that doesn't always hit the emotional thing that a relationship needs in terms of like getting to that understanding of like, this is a need. This is not just like, I want to sit in the shade. It's like, I gotta be in the shade. So, yeah, I think that's my question.
Lorena, you want to start?
It's a great question. Because yeah, I feel like that's something that we'll deal with for like the rest of our lives, right? But I've found that the people who actually care about your well-being and your mental health and just love you for you will understand, and you don't need to explain. I mean, you can, when you first meet someone, and then it's up to them to, want to learn and ask. And I encourage everyone to ask, like, if they have any questions, to, because it's very rare that someone knows the in and outs, right, of this autoimmune disease. So education is key, and if they want to know more, I'm more than happy to. But I'm not going to compromise like my well-being or compromise who I am for the comfort of someone else, right? If they truly unconditionally support me or love me, they'll do their best.
To add to that, I would just say having strict boundaries is really important and always putting yourself first. I mean, the autoimmune journey for me has gotten very lonely, but then I've also met so many great people. And I think it's kind of funny because when I look at my friend circle and like my close relationships, almost everybody has some sort of diagnosis. They may not be autoimmune, but it's some sort of chronic condition. So I feel like I can really relate to a lot of people in my circle because even though when we met, like most of them were healthy, it's like as we went on into our adulthood, it just seemed like a lot of people were getting, more conditions and they had to make lifestyle changes. So, we're very fortunate that we live in a world today where it's so accessible.
We have a question online for both of you. It says, what are the biggest things that have helped you be able to thrive while working or pursuing school?
I would say a support system is really important to be able to thrive in the workspace. I would also say advocating for yourself is very important. I work in healthcare, so I've gotten very lucky with my attendings and being able to have them understand and let me sit down and not feeling well. I would also say taking care of yourself and setting those boundaries. Finding jobs that are able to like be a little bit more flexible with you if possible. And I would say definitely like eating a healthy diet and making sure that you're set up for success each day. And things that I like to do for that is like, if I know I'm gonna have the busy day next day, I'm gonna make sure like the night before I set everything up so I can preserve my spoons until the next day. So making sure that you're always just trying to take care of yourself.
I would add to that, you are your best advocate. You know yourself the best, So I would say just knowing your limitations, and adjusting your lifestyle according to that, and having a great support system. I have a great support system in my mom and my brother, and they've been a great help. I have a dog. She's my emotional everything. So she brings a lot of joy. And not being afraid to stand up for yourself, whether that's in the workplace or in school, and being, your best advocate, because no one else is gonna, stand up for yourself and know your needs or accommodations.
Hi. Is it on? Hi. I just wanted to know, what are some things that you would hope that the village around you, your relatives, friends, partners, would know, or would like them to know, or I guess support you when you're going through flare-ups? What's the best thing that they could know so that they could help you and be there for you and support you in those times?
I would say for me, they're very aware of like when my symptoms start. So I get very quiet before a lupus flare. So if I'm in the car with my friends and we're all like having fun and I suddenly get silent, they know like, okay, she's maybe not feeling well. So also they know that sometimes cold can trigger me. So like my friends are so considerate. They'll like bring extra blankets and jackets for me. Or if I'm having a migraine and I don't feel well, like they will DoorDash me food, which I think is really sweet. And I live in Orange County, so there's plenty of places to DoorDash from that are anti-inflammatory, which I really appreciate. And honestly, just having a friend pick up the phone when you need a vent, when you've had like a rough appointment, a rough day, a rough few days, just having someone there to listen really helps.
Yeah, I would say listen and understand. And also, sometimes, I don't know, we can't control like our moods and we can't explain. So just don't take it personally and just, yeah, know that we appreciate the support.
We have a question online. A little bit of an explanation. This person says, I've taken a leave of absence from work at 2 instances in the past. These were times when dealing with flares and waiting for new therapies. But now I'm struggling with stress management, flares, but no change in therapy, and fatigue with lack of focus. It doesn't feel severe enough to take a leave, even though that is likely what will help me get out of it. How do you take the leap to make the difficult decision to take a leave?
I would say it's putting yourself first, right? It's about, you have to think about, is my health worth any job, any relationship, any other person other than myself? And usually the answer is no, your health is worth more than anything else in the world. Like you only have your health once. So if that means having to take a leave and having to put yourself first and take that time so that you can take care of yourself, I think it's writing down the reasons why you deserve to be able to rest. And more than ever, you should always remember that like you should come first and your health is very important.
So I am a birth and lactation doula as well as a patient with an overlap syndrome. And my question has to do with professionals. So it has kind of 2 parts. The first part is, what have you been thinking about lately that you would like the professionals that you encounter, the doctors and the caregivers and everything that you encounter to know that is on your mind, that you're hoping that they would know for your care? And the second part is, if you are at the doctor, you're having a medical encounter, and there's someone there supporting you, what's the most important thing for that support person that that you can think of right now?
Great questions. Ladies?
I would say in a professional setting, especially since I've worked with many doctors and nurses, I would say one of the things that is very important to note is that these diseases are real and the symptoms are real. I've worked with some physicians who have said it's just fatigue or it's just dehydration. And so times like that, it's like having to speak up and really educate. It sucks having to educate doctors about, these diseases are real. And I would say for the support system during a doctor's appointment, I think they should be your biggest advocate as well as you should, because sometimes the doctor may not be hearing what you're saying. So having a second person there to really validate what you've been feeling and really advocate for you is really beneficial during those visits.
Yeah, I would say advocate and listen. And in the professional, I think, again, you are your best advocate and being very firm with that, right? It's not a question, it's a statement. Like, this is what I'm feeling, this is what's going on. And hopefully your doctor will be able to help you.
We have a question online. How do you ladies go about disclosing your condition to employers or professors? Or do you selectively choose their citing that they're also a filmmaker and have struggled with this?
How do you disclose?
Yeah, whoever this person is, they're saying, how do you go about disclosing, or do you just selectively choose who you're disclosing with?
I don't know. I think when I was younger, my answer probably would have been different. But as I've gotten older and I've realized, you know, it's been life altering, but in the best way. And I want to be able to be a light or inspire or be someone that other lupus patients can look up to, as well as, these lovely ladies, that, we didn't let this disease detour us in our hopes and dreams and what we decided to pursue with our life, right? Yet there's been roadblocks, but it hasn't hindered us, right? It's made us more determined to really do what we love. And so now I am very vocal and I want to educate. So I think now more than anything, it's something that I carry with a lot of pride, and I try to, again, the more people that know about this disease and other invisible diseases, the more that there could be less of a taboo and more education around it, and hopefully more support and medicine and science that can one day change it.
Before we go on, I just want to welcome Cambria, who is also a part of our patient advocacy panel and just arrived. Cambria, would like to take a moment and introduce yourself?
Sure.
You're going to.
Okay. Hello. Hi. Apologize for the CPT, but I am so glad to be here. I'm Cambria Francesca, or Cambria Anderson. I am a model, a travel content creator, and a lupus patient of about 20 years. I am extremely grateful to be here. These are amazing co-hosts, and I can't wait to talk to all of you.
We'll sort of jump into this last question so you can participate. And that question was, how do you go about disclosing your condition to employers or professors? Or do you selectively choose whether to disclose?
I actually just had this conversation with my little sister because she is a burn survivor, and her disability or her body difference isn't obvious, and neither is mine. And so we were talking about whether or not it was something that she felt compelled to tell people about and if it affected her. And for me, for a very long time, I felt like my existence and survival depended on people knowing. Because if I didn't tell them, if I didn't educate them, all of the questions that they had and all of the things that they were making up in their minds, 9 times out of 10 were negative or weren't to the benefit of me or didn't give me a benefit, or, it was a situation where no one's going to understand what you're going through if you don't tell them. And now I'm in a different position to where I do understand that there are backlashes depending on what industry you're in. I am looking at different opportunities right now. I've been applying to different types of jobs, and there's that little button right there that says, oh, do you identify as someone with a disability? And I'm like, what are the pros and cons of this? But I feel like if I have the bravery enough to do it and to talk about the accessibility needs and to tell people, hey, these are the gaps in your system, then maybe the next person after me won't have it as hard.
Okay, we have a question over here.
Good afternoon. Sorry, I'm very nervous. So I suffer from untreatable depression, which is my lupus cause. Do you have any recommendations for somebody who struggles with depression related to lupus?
Go for it. Hi. Oh, one more. I understand that depression isn't something that we just wake up one day and be like, oh, go try something different. And you wake up and feel different. But for me, it was little things, and it started with my environment. I realized that my depression was triggered by not having a regulated nervous system and not having my environment be a place of peace. So I had to start at home. If my home life, if my home space was not somewhere that I could walk in and feel like, and I could lay it all down, then that's where I start. That's where you start.
It's wonderful advice. Question online. How do you ladies talk to? I'm
going to
sorry.
add a little bit to that. I also wanted to add something that I do is keep a gratitude journal, which really helps me remind about the little things. And it can be something so simple as like, I got up today, or I opened my eyes without pains today, or I was able to make myself breakfast, or I walked 10 more steps than yesterday. And I feel like that's really helped me get out of a funk, or when I don't feel well, or when I'm having those depression symptoms. The gratitude journal helps.
Do you like to go out, like on walks? I do, but it's really hard because my lupus limits me doing it, and also because I get really anxious and I don't know, I get fear of the unknown. So if I'm out, I don't know what's gonna happen to me, or that's why I'm getting I get TMS treatment too for my depression, and it has escalated to the point where I get tremors, and I don't know if it's because of the lupus or because it's something else, but when I get really nervous, it's because I'm going out or trying something new. Okay. That was because I was going to recommend just like going 5 minutes, just go outside, get some fresh air, try to clear your mind.
I also want to acknowledge that you're here, and that's brave. And you're participating, which is also extremely brave. So give yourself credit for that. How do you ladies talk to people who might make negative comments about your need to slow down or adjust plans at the last minute, whether it's friends or family?
I would say since I work in healthcare, I have been called slow before by a physician, and that was 3 weeks post-op of my hip replacement. And yeah, I actually had 2 hip replacements done due to vascular necrosis from prednisone. And I was working as a medical assistant at that time, and I went back to work before I was supposed to because we were short-staffed. And during those times when I was called slow, at first I didn't say anything and I held it internally. And then I actually did tell the doctor that, you know, even though I am, at the time I was 22 years old, I was like, even though I am young, I'm still sick. And I just had a major surgery. And I'm here working for you. I'm helping you. So if you could just give me a little bit of grace, like that is the bare minimum that I deserve. And he gave me the grace and he apologized. And so it's about holding people accountable. And it's like, you know, we are sick and our realities are very real and we should advocate for ourselves and speak up.
Susan, we have someone back. Oh, I'm sorry. Someone else going to answer too.
Yeah.
Sorry about that.
I'm going to be honest. I'm the wrong one to ask because I'm petty. So most of the time I hang up or walk away, or if it's someone who I feel like one is open to being educated and is just making a foolish mistake and not taking into account all of the situation, then I put in the effort. But honestly, I've had to learn to protect my peace, and there are a lot of ignorant people in the world who are comfortable with their ignorance. So I'm gonna leave you where you're at.
We have a question.
Hi. I really appreciate you guys being here. Because of my lupus, which I've had for over 20 years, it's done a lot to me where I have probably 7 specialists I go to. I had a job working in the music business for 30 years. working with artists. And it just became, it was just, I couldn't do it anymore because of my health. And now I'm kind of able to work full time, but I'm finding because of my medical issues, I have like sometimes 3, 4, 5 doctor appointments a week. And it's really difficult to hold a job when you're constantly going to, you've got to go back to the cardiologist and they had to take out your thyroid because the lupus made your thyroid overactive and like just all over your body it's like, oh, now there's this. And I just wondered what kind of career things you've heard of people have done when they do have a wacky schedule and constantly have these interruptions from medical appointments that have been dominating like my life.
Anyone?
Traditional job. Yeah. And a traditional job. That would be the more traditional job.
So the reason why I chose nursing was because of the flexibility. And so in the healthcare industry, there's actually many jobs that people can break into that are remote. There are remote triage nurses. There are per diem nurses, which make almost double the base pay of a staff nurse. And so you can work less and make more. And also there's concierge nursing. And so looking into different avenues of your career path that may have more flexibility, they're more like as needed is something that you can look into if you're in healthcare. But that's my perspective just from the nursing profession.
I have a non-traditional job. I work in entertainment, and so my job is literally just you call and hey, can you work? So I'm used to that type of schedule. So I specifically picked work that does that. But when it comes to side income, I try and do everything mostly remote. And it is hard. I have a friend right now who is on Social Security and wants to have a full-time job, but cannot find a remote job, even though she has all of the qualifications. So finding people within your industry who have moved themselves to remote and talking to them, finding out how they did it, what they did, who's in the connected. Because I feel like, especially as we get deeper and deeper into all of our careers, a lot of us want to be at least part-time remote. So the conversations need to grow. We need to start pushing our employers to allow us to have these accessible needs, that this is not just for disabled people, it's not just for sick people, it's not just a part-time thing. This is so people can have balanced, healthy lives.
Thank you.
Hi there. I've had lupus going on 58 years, and I need to go back to work to substantiate my life. And I'm really, really reluctant to share the fact that I have all these issues going on with my health. And I'm wondering, is there a really good way that I can not really come right out and say, okay, I really have all these things going on, but I need to go back to work. I mean, I'm a senior citizen, believe it or not. So it's really challenging. Do you have any advice for me so I don't look like I'm, that poor little soul that needs to find a job?
Mm-hmm.
Wow.
Okay.
I think they're thinking about it.
Yes, we are. I think for a lot of it, some of it is attitude. If you go in feeling and acting like you're a burden to this system, then they're going to respond that way. So if you go in saying, hi, these are all of my qualifications, I'm fully ready and capable of taking this job on, but I also am going to need these accommodations. And it's just, that's what it is. It's not putting any emotion behind it. They don't need a whole bunch of details about why. Just these are the accommodations that I need to be employed and to give you the best of my work ethic that I can give.
And every place I applied for, I got turned down for 10 different places, all over the spectrum. It's like,
But they can't. Sorry, they can't hear you, the interpreters.
okay. Well, I did apply for work prior to November. And then I had this lovely accident that broke my femur and that put me out of commission completely. I just don't want to walk in. I mean, I applied at like 10 different places and every one of them turned me down. And it's like, okay, do I say that I have something wrong? Or do I just keep it to myself and act like, you know, I'm just like everybody else? I mean,
Yeah.
I'm going to be 71 and this is how I dress when I'm hanging out.
Right.
So
honestly, I feel like that's a hard question simply just because what works when you go into one place might not work when you go into another place. In the era that we're in right now, it was like everybody is applying and getting turned down. So it might not just be that, but I feel like if you feel that your disability is something that you 100% are going to need accommodations for, letting them know is just the strongest in my position. But I can only give you my opinion.
Yeah, I agree. If it's something you feel like is essential to being able to perform at your job, I would let them know. But again, not making it like it's gonna hinder your performance in any way. And keep applying. I mean, just the work space right now is awful. So don't take it personally and keep on going.
And also on the job applications, you can say you have a disability or not, or say prefer not to disclose. And I usually put prefer not to disclose. So I can just, when I get hired, I tell them these are the things that I need. But I also make sure I read all the qualifications first to make sure I'm able to do everything that's listed. But if you feel like I don't want to say that I have something, I'm scared it's going to like affect me negatively when I apply, you can always just say prefer not to disclose.
Anybody else? Thank you so much, ladies. We really appreciate it. We're going to have you guys each pick one of our raffle tickets. So if Megan can sort of bring those up.
All right, get your tickets ready. Hi, everybody. Everybody have your tickets?
So you can give each one of them.
Okay.
Megan, you can give the box to the lady.
Oh. Yes, please.
You guys want to read the numbers?
Sure.
Pick one.
Actually, we all got we were all holding it like here. Joint effort.
Okay, who's going to say the number? You're going to say it first?
Yeah, Lorena,
Okay.
go first.
730159.
Hey.
Stay there. We'll bring that to you.
730303.
That one gets to go to me.
Again.
Okay.
730227.
This is a hot corner over here.
Okay.
730168. Oh, okay. Let's do it again.
Oh, here we go.
Hey.
We have a winner. All right. Thank you, everybody, for coming today. Thank you, everybody, for live streaming. We've had a really nice community online. And again, if you want to reach any of us, info@lupusla.org, any doctor information, we will have the slides to share. We'll post probably on YouTube in a day or two. The whole conference will be up. And thank you, ladies, for joining us today. We appreciate it.
Thank you.
Oh, Yeah, for everybody in the room, take food. Okay. We have dishes, we have extra muffins. Please help yourselves. You might as well have dinner.
It was gonna happen. Yeah, of course.